Good evening, respected chairpersons, esteemed speakers, and dear colleagues. It's my great pleasure to welcome you all to the MP ISAR annual CME dedicated to one of the most challenging topic in reproductive medicine, that is endometriosis. So today's academic session brings together leading experts to discuss imaging, stimulation protocols, surgical approaches, and IVF strategies in endometriosis. I'm confident as that the insightful talks and the panel discussion will enhance our understanding and help us translate evidence into better patient care. So, on behalf of the organizing team, I thank you all for joining today and contribute to this enriching academic evening. To start the lamp lighting, I hand over the session to Dr. Rudri Agrawal.
Thank you so much, ma'am. And I extend my heartfelt welcome to each and every delegate and guest who have joined us from all over India. So, without much ado, let us begin the MP annual ISAR CME with the choices blessing and by seeking the choices blessing of Goddess Saraswati. So, may we have the lamp lighting video, please? Bhakti, can we have the video, please?
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं
Thank you, Bhakti. Thank you, UNS team, for the technical support. Now, I request Dr. Kalyani Srimali ma'am to take the session forward and welcome Dr. Archana Basir ma'am and to introduce Dr. Archana Basir ma'am for all of us. Dr. Kalyani ma'am, are you there?
Yeah. Good evening, everyone, and welcome to the Central ISAR MP ISAR annual CME for today. Dr. Archana Basir is a distinguished national leader in obstetrics and gynecology, an accomplished clinician, academician, and visionary organizer. Consistently contributed to shaping the direction of the women's healthcare in India. As consultant and gynecologist and director at Akash Hospital in Indore, he brings together decades of clinical excellence and impactful professional leadership and organizational strength. She has served the Federation with dedication across multiple responsible positions, including the Vice President FOXY 2020, Chairperson MP ISAR 2025 to 27, FOXY Fellow Representative AICC RCOG West Zone, Joint Secretary ISAR, and Organizing Secretary AICOG 2021 Indore, demonstrating her ability to lead a city, state, and national levels. Her past contributions further include Chairperson FOXY, Imaging Science Committee, Organizing Secretary ISAR, IAGA, and active roles in the Imaging Science Committees of FOG and SUFOG, reflecting her sustained commitment to academic advancement, scientific growth, and strengthening of the professional bodies. As she moves forward in the upcoming Foxy presidential election, we extend our heartfelt best wishes for her continued success and leadership in guiding the Federation towards the greater unity, progress, and excellence in the women's healthcare. Welcome, Archana Basai, ma'am.
Thank you, Kalyani, for the kind words and introduction. At the outset, let me welcome all the distinguished faculties who have joined here. And this is an annual MP ISAR CME. We have completed our 1 year. When I took over on the 2nd March last year, along with Dr. Brishbala as my secretary, we have been awarded the one of the best chapters by the ISAR. It is because of the constant effort of all the members of our MP ISAR, as well as blessing and advice of our seniors like Dr. Gada and Dr. Asha Bakshi, who are the people who started MP ISAR chapter. Dr. Gada was the national president and advisor, and Dr. Bakshi is the first founder chairperson of MP ISAR. Without their support, we would not have reached here. And all the faculties who have joined, Dr. From all across India, I welcome all of them to participate in this. And with the current president, Dr. Sunita Tandulwalkar and Dr. Ashish Kale as secretary, they have also sent their blessings to our workshop and the CME. I would now like to invite Dr. Gada, our guest of honor, to address the audience. Can I have the CV of Dr. Gada? Dr. Gada is basically is one, what can I say? He's a legend in infertility practice, and he is the godfather of many, and he's mentor of mentors in across the India, especially in Indore. We all consider him as a godfather of infertility. He started his practice in 1978, and he was first to deliver IVF baby in state of Madhya Pradesh, and he has many publications. He was organizing chairperson of ISAR 2003, successfully organized IFFS 2016, and has been honored by Lifetime Achievement Award by ISAR and Indian Fertility Association. And we recently had one oration in the name of Dr. Gada, which we initiated in the MP ISAR annual conference last year. So over to you, sir, for your blessings and advice and continuous support you have given to us for going on with the MPSR activity.
Thank you very much, Dr. Rachna Baser. It's my pleasure always to be with you. You have been doing very well with the ISAR. Under guidance of Dr. Asha Bakshi, Rachna Baser is progressing very well, and I am very happy to inform you that she is contesting for the post of President of Foxy. I wish all the success to her. About this CME, it is very well organized CME, and I wish all success for this CME. All the best to Dr. Archana Baser and whole team of MP ISAR. Thank you very much.
Thank you, sir. Thank you for your kind words and blessings. And please stay with us for some time, because this CME is dedicated entirely to endometriosis. And we know that this is the endometriosis month, and endometriosis still poses a problem. And all the speakers who are going to be talking about endometriosis, Dr. Ramani Devi, Dr. Agrawal, Dr. Pratik Tambe, and Dr. Jyoti Malik. So different aspects of endometriosis we are going to be covering. And we have a panel discussion by Dr. Chaitanya Shambekar on case scenarios of endometriosis. So now I would like to invite our next guest of honor, who is none other than the Vice President of National ISAR and our founder chairperson of MP ISAR, Dr. Asha Bakshi. Can I have CV of Dr. Asha Bakshi, please? I think everyone knows Dr. Asha Bakshi. She is currently the Vice President of National ISAR, and she has been member executive committee, AICC RCOG, chairperson of Foxy Infertility Committee. I mean, she has held so many positions, and she has so many first to her credit. And Dr. Bakshi has been awarded with first ICSI, TISA, ICSI and Micro TC Babies of MP, recipient of Kumud Tamaskar Award, sorry. And she has organized so many conferences, and she is basically a really legend, and she is the person who we looks up at, and she's a role model to many of us, ever energetic, ever guiding, and ever problem solving person for us is Dr. Asha Bakshi. And currently she is advisor of the upcoming conference of National Vice President, which is going to be in Indore 8th, 9th, and 10th of May. So over to you, Asha Di, for your advice and your inputs on how MPSR has been doing and what more we can do for MPSR and all our members, executives, and even non-executive to go up in the ISAR and participate in its activities.
Thank you. Thank you, Archana, for the kind words. And I'm so pleased to see the Pitama of infertility in Indore, Dr. Gada. Thank you, Dr. Gada, for all your blessings, your guidance. And MPSR chapter is what today is because of your guidance. And congratulate the MPSR team being led by Dr. Archana Base, Dr. Brajbala Tiwari, Dr. Shweta Kaul and Dr. Gajen Tomar, because recently we have been awarded with the Rajat Ray Award as Best Chapter. So it's really a great achievement, and I can see all the activities that you have done in the last year. And today you have really selected a very good topic, and that is on endometriosis, because we all know that endometriosis is a neuroendocrinology problem, very irritating and a very chronic problem. And lots of new things are coming up these days, including non-hormonal treatment, lifestyle management. So it's very, and then diagnosis is very important, and this part has been well covered, because almost 5 to 7 years, it takes almost 5 to 7 years to diagnose the disease after its onset. So, and patients keep on moving from one place to other. So very important to have this awareness, not only amongst the gynecologists, but I would say amongst other specialties also. So the topic is really, and especially this is the endometriosis month. So it is very relevant, and the speakers are also very good. And Dr. Archana Base, I would like to say that she is a mastermind, and she really organizes things very meticulously. And I've been with her since last almost 25-30 years, and I'm watching her how meticulous she is. And I feel that she will really bring laurels to our city by becoming the president of Foxy. So my best wishes to you, Archana. Go all out, do well, and I'm sure the victory will be yours. So all the best, and thank you very much, and wishing you a very happy CME ahead.
Thank you, Ashadi. I mean, your kind words and your encouragement always keeps us going. I always remember your one word, that gynecologists have a lot of endurance, and whatever, howsoever tired you may be, but when you see the next, I think you keep going. So all out is the one word I have really imbibed from you, and I'm sure I'll do as expected from me. So thank you very much. And now, do we have Dr. Ashish Kale or Dr. Anu Chawla with us, Dr. Rudri?
Yes, ma'am. Thank you, ma'am. Thank you so much. So I request Kalyani ma'am to take the session forward and kindly introduce Dr. Brajbala ma'am for all of us.
Yeah, Dr. Brajbala will just give a brief report of what all we did in MPSR last year.
Dr. Kalyani ma'am, are you there? Dr. Kalyani ma'am, are you there?
I'll just introduce Bala ma'am.
Yes, I'm here.
Yes, ma'am. Ma'am, kindly introduce Brajbala ma'am.
Welcome, Dr. Brajbala ma'am. She's the chairperson for Foxy Environmental Health Committee 2025 to 2027. She's also the secretary for MP ISA 2025 to 27, secretary ISOPAP chapter Indore 23 to 25, past president Indore OBGY Society 22 to 23. She was also the vice president of the Indore Menopause chapter, past vice president IMA 2021, past secretary IMA 2018-19.
Thank you, Kalyani.
And many more. And she is also the managing director for Life Care Hospital, Santati Infertility Test Tube Center, and LCH Nursing Academy. Welcome, ma'am.
Thank you, Dr. Kalyani, for your kind word of introduction. And good evening to all esteemed faculty and our patron of MPSR. And because of Dr. Gada, everyone knows Indore and infertility, and founder chair, Dr. Asha Bakshi Madam. My gratitude to both of you and all the esteemed faculty and speaker today. So as last year on 2nd March, MP's new team took over under the able guidance of Dr. Rachna Basir Madam, and as the guided by Dr. Bakshi and Dr. Gada sir and all the past VPs of MPSR, many activities were done by MP chapter Isar. There were quarterly news bulletin was started by MPSR, and till now 4 news bulletin on endometriosis, fibroid, environment, and infertility were published. Online e-news letter was published by MP Chapresa, having many good articles and so many awareness activities in medical colleges about infertility and social activities. And because of that only the MP chapter could receive this prestigious Rajat Ray Award, and it was the guidance by Dr. Basir and Dr. Bakshi Madam, we could achieve this. And there were many CMEs in different cities, like in Bhopal, Gwalior, Jabalpur, and other places. Many CMEs were organized, and
आज सारा काम में 3 घंटा ओटी के अंदर क्या चलेगा ये सब गड़बड़ कर दिया
Dr. Kanchan ma'am.
Dr. Kanchan ma'am.
Ma'am, can you mute yourself?
आप मुझे ब्लेम कर रही हो
so we are
Dr. Kanchan.
always encouraged by
sorry.
Dr. Gada sir and Bakshi madam and Basir madam to do many activities, and all the members of executive committee MPs are helping in doing all these activities, and regular monthly webinars, bi-weekly by fortnight webinars MPSR is conducting. So this is the month of March and we are celebrating endometriosis month, and for that Madam has Basir Madam has chosen this topic of endometriosis because this is related with infertility, and we are having esteemed faculties Dr. Jyoti Malik, Dr. Ramni Devi, Dr. Ajay Agrawal, Dr. Archana Basir Madam herself, and the panel with Dr. Pratik Nambe and panel by Dr. Chetan Shambekar. So we are going to have good academic session, and we always need blessings from Gada sir and Bakshi Madam. Keep us guiding, and my sincere humble request to each and everyone, all the faculties and delegates, to support Archana Basir Madam for this upcoming Foxy election president post. Madam is really well deserving and very, very active academically, and I'm observing since last, though I know Madam since so many years, but since last 1 year, I am seeing Madam is so particular, so meticulous, and she takes everyone all together in making any program, and she takes care of each and every member of everyone. So my sincere wish that Madam should come as Foxy President. Thank you so much.
Thank you, Brijbala, for the kind words and reports.
Thank you, ma'am. Can we start a scientific session, ma'am? Can we go forward?
Yes, please. Yes, please.
Yes. Thank you, ma'am. So I request Dr. Dipti Gupta, ma'am, to take the session forward and to kindly introduce our chairperson so that we can go ahead with a scientific session.
Thank you so much, Rudri. Good evening, everyone. Greetings and regards to all esteemed dignitaries, and it is a pleasure and honor to be amongst the who is who of infertility in Madhya Pradesh, respected Gada sir, Bakshi ma'am, Basir ma'am, and also sharing the platform with our dynamic speakers, Pratik sir, Jyoti Malik ma'am, Chaitanya sir, and congratulations, Basir ma'am and Brijbala ma'am, for a phenomenal 1 year and winning the Best Chapter Award. Taking the scientific session forward, I would like to introduce and welcome the chairpersons for the first session. Bhakti, can I have the CVs, please? So first and foremost, our own Rakhi Bajpayee ma'am, who's currently the president of Jabalpur OBGYN Society and also an infertility and IVF specialist. Ma'am has been the zonal chairperson and held various other positions. She's won awards for TSPMA by Anti-Government Bharat Excellence Award. She's had a biography in Asian American Who is Who, and she's been conducting various awareness programs. And most of all, in the last 1 year, we have seen the resilience, the love, affection with which she has worked diligently. So, welcome, Rakhi ma'am. Next chairperson for the session, we have Dr. Arpita Gandhi ma'am. Arpita ma'am is founder president of Devgarh OBGYN Society, also life member of all the prestigious national organizations like IMA, FOXY, ISOPAB, member of Safe Motherhood Committee, FOXY, also received the Best Doctors Award from Bharat Vikas Parishad, Jharkhand, Bengal Samiti and Lions Club Devgarh, with special interest in ectopic pregnancy, including scar pregnancies and secondary PPH. And she's not only that, she's been, giving monetary help to poor cancer patients as well, and to poor and meritorious students as well, which is amazing, ma'am. It is an honor and privilege to have you with us. And of course, she has conducted many academic events under the banner of ROGS in 2005. Welcome, ma'am. And last but not the least, we have Brijbala Tiwari ma'am as the third chairperson for this session. Brijbala Tiwari ma'am, we've already heard and been introduced to. It is a pleasure having you with us, ma'am. Over to the chairpersons for the scientific session.
So may I request Dr. Rakhi ma'am is there or Arpita ma'am is there to introduce our first speaker?
Ma'am, Arpita ma'am was here.
Yeah.
I'm being introduced, so it's okay. Is Dr. Arpita joining?
Yes,
Ma'am,
madam is busy.
Yes, yes, I have joined.
Yeah, madam is there.
Balaji, I have joined.
Yes, ma'am. Thank you so
I am
much.
joined.
Thank you so much, ma'am.
Archana
Ma'am,
Basir, madam, I met you in Gaya ji,
Yes.
and my best wishes. And it is not only that I will vote for you, I will pray to Lord Baidyanath for your success.
Thank you, ma'am.
And
Thank you so
after
much.
winning, you have to come to Devgarh once.
Yes, I will come. Definitely. What happened? Yeah, I'm just going. I think we did check, but yeah, and play from the start. Is it playing? Yeah. Yeah, you can see now. Yeah. So at the outset, let me thank my team for organizing this MPSR CME. These are the mammoth efforts of the two webinars which were simultaneously going on, Zoonosis and Fertilogics. Zoonosis, Dr. Dipti Gupta, Dr. Manila Kaushal, Fertilogics, Dr. Brijbala Tiwari, Dr. Kalyani Shrimali, and Dr. Rudri Agrawal. They both teams have said we should do a combined CME by taking this topic, because endometriosis is a big topic, and just you cannot have one or two talks. You should cover everything about the endometriosis. So thank you, my team, and all five of you for really bringing in this program, and UNS for giving us the platform. Let me begin with my talk. Endometriosis, stepwise diagnosis of endometriosis, because before we begin with treatment modalities and how really to handle endometriosis, let's just quickly go through how you should diagnose endometriosis. Endometriosis is a costly chronic disease, as we know, and nearly 10% of women of reproductive age group suffer from endometriosis. And certain facts and figures of endometriosis, as we know that 10%, 1 in 10 have endometriosis. It takes an average of 7 years for most women to get diagnosed, as was mentioned by Dr. Asha Bakshi as well. Endometriosis can often be confused with or misdiagnosed as irritable bowel syndrome. And endometriosis, remember, is the second most common gynecological condition after the fibroids. So just an overview of my talk. I'm just going to take you through ultrasound appearance of endometriosis within the pelvis, how to assess the pelvic mobility, and what to look for during an endometriosis scan. So endometriosis, I think endometriomas, adhesion and endometriotic nodule, deep or superficial, that's what we will be looking through the ultrasound. And this is how endometriosis typically manifests in the 3 ways. Now, diagnostic modalities we have is clinical ultrasound, contrast ultrasound, MRI, CT, endoscopy. Will be having good lectures by Dr. Ramani talking about the other methods of screening the endometriosis and histopathology definitive diagnosis. So ultrasound is the most preferred modality for assessment of pelvic pathology, and you can do it by transvaginal, transabdominal, and transrectal. But I would always recommend that even if you're doing a transvaginal scan, you may be a good infertility scan person. But if you are suspecting an endometriosis or you are seeing endometriomas, please do an abdominal scan as well to look at the kidneys and the ureters as well, because in the deep invasive endometriosis, you need to know the status of ureter and kidneys as well. So ultrasound, why ultrasound? Because it is widely available, it is cost effective. Ultrasound scan can pick up ovarian lesion, endometrioma, deep invasive endometriosis. This all we will be looking at. Now, scanning technique, just grayscale imaging can be improved by HI-CRI. With this, even subtle textural changes associated with endometriosis can be appreciated. These are the surgical staging of endometriosis: minimal, mild, moderate disease, and the severe disease. This is how you put it on the pictures in your laparoscopy. When you do the laparoscopy, just put it on a graph that where all the lesions are there in endometriosis. In olden days, we were used to do this. Nowadays, we have the recording systems, image, where you can take the printouts, and that way it can be done. So everybody has different ways of putting it on the papers that what is the grade of endometriosis. You can use any classification for endometriosis. Just for the purpose of this lecture, I have simplified the staging on ultrasound endometriosis. I'll be describing how to identify structures involved by endometriosis, showing corresponding laparoscopic image to improve the correlation, and this can be staged by any classification or system you are comfortable with. Let's go step by step. So what are the structures which get involved in endometriosis? We know ovaries, uterosacral ligaments, bowel, rectum, bladder, and uterus. Ovarian endometriomas are the most commonly diagnosed form of endometriosis because of relative ease and accuracy of ultrasound diagnosis. And although their exact prevalence and incidence are not known, they have been reported in 17 to 44% of women with endometriosis, and presence of ovarian endometriosis has been reported as marker of deep invasive endometriosis and multifocal deep vaginal, intestinal, and ureteric lesion. Now, ovarian endometriomas, they are common. They can mimic other adnexal masses as well. So endometriomas result from cyclical hemorrhage. The walls are thick and fibrotic. The contents consist of thick, dark, degenerate blood products, also known as chocolate cyst. If unilateral, they are more likely to occur within the left ovary. And if they are bilateral, approximately 50% of cases they can be, and usually regress after the menopause. Now, this is a typical feature of endometrioma. There are fluid levels. The hyperechoic layer will be dependent portion of the cyst. They can have calcified foci within the cyst, acoustic shadowing, typically avascular, or there is a low flow, and acoustic streaming can help discriminate it from mucinous and serous cyst adenoma. So this is a typical endometrioma with the ground glass appearance and little bit of a cholesterol deposit here. So this is again an ovarian endometrioma. Now, the most important thing is endometriosis may not always look the same. Notice the cholesterol deposit in this clear looking cyst. So someone might report is a follicular cyst or a clear cyst. So it is important that it is, if depending on the patient's complaint and patient symptom, and looking at if you see any kind of these structures, just go in detail, do a streaming and see what cyst it is. So this is how cholesterol deposits will look like in endometriotic cyst. Now, this is the image of the same patient showing the ovaries stuck behind the uterus. This is a sagittal section on the sonography with the uterus. This is a endometrial thing. And if ovary is in a normal position, you should not be seeing it in a sagittal section. In transverse section, you should be ovaries. If you are seeing it here, especially near the cervix, you can think of that, yes, probably I'm dealing with stuck ovaries which are stuck behind the uterus. And this is the laparoscopic view of the same patient where the ovaries are stuck behind the uterus. Now, the most important thing is there can be multiple ovarian endometriomas in the same ovary. And it is very, very important that we map all the endometriomas in the ovary. Now, this is a clip showing multiple endometriosis in the same ovary. It is important that it is made prior to surgery to avoid the residual endometriosis. If you do not do a mapping, you miss out. You just take the larger one and you leave the smaller one, which will grow in due course of time, and you will say, well, it has recurred while it was the leftover disease from the previous, from the first surgery. So it is important that we have high resolution ultrasounds available, good modalities of diagnosis is available. So we should do a proper mapping of endometriosis and endometriotic lesions before we contemplate surgery. Or during surgery, it is important that we remove the disease completely. So this is again an image showing multiple endometriomas in the same ovary, and it is important that we assess prior to surgery to avoid the residual endometriosis. Again, ovarian endometriomas with the little cholesterol deposits here. And this is the laparoscopic picture of the same endometrioma. And this you see, this is again an adenomyotic uterus, because endometriosis and adenomyosis more or less they go together, because what we have found in the practice, they are almost like cousins. You will find if there is endometriosis, you will have uterus also adenomyosis. So these are the again ovarian endometrioma. These small endometriotic lesions are usually uniform and slightly hyperechoic than the stroma. And what is most important thing about the endometriomas is they do not change their ecostructure during different phase of menstrual cycle. So if you have seen some cyst premenstrual or during menstrual or the postmenstrual phase, the structure will remain the same, while it is different with other kinds of the ovarian cyst. So this is again the endometriosis. You can see these are the large endometriomas, and this is a laparoscopic picture of this large endometrioma. And this is again the ovarian cyst with a large endometrioma you can see here. Now, differential diagnosis of endometrioma, you should differentiate it from dermoid cyst, hemorrhagic cyst of ovary, serous cyst adenoma, and pseudocyst adenoma. This is the endometrioma. This is a little bit of a ground glass appearance here, but the most differentiating point here is the dermoid plug, which is a tough hair, which is invariably going to be there in the dermoid cyst. So that's how you can differentiate endometrioma from the dermoid. And this is a hemorrhagic ovarian cyst with a cobweb kind of appearance, fibrin strains, and a little bit of fluid here. And this is a serous cyst adenoma, which is a clear unilocular cyst filled with a clear watery fluid. And this is pseudocyst adenoma, usually seen as large multilocular cyst containing fluids of various viscosity, and they rarely appear as unilocular cyst. And the same cyst seen in the laparoscopy. So this is a picture like how what you see on the ultrasound, exactly similar thing you will be seeing on laparoscopy. So your diagnosis has to be really good on the ultrasound. Now, endometrioma rules are single base discriminator between endometrioma and other cysts is the ground glass echogenicity, and sensitivity of it is 73% and specificity is 94%. And invariably it is in premenopausal women, 1 to 4 locules and absence of papillation with detectable blood flow. And ovarian endometrioma only are rarely the sole finding. If you are seeing ovarian endometriosis, remember that it is your stage 4 and you're already may you be finding the deep invasive endometriosis. So women with endometriomas have more pelvic and intestinal areas invaded by endometriosis compared to women without ovarian endometriosis. So it is important to identify other structures involved. So what we have learned so far in the past also, that you find the kissing ovaries, both ovaries are joined behind the uterus in the pouch of Douglas, negative sliding sign, and these are strongly associated with presence of endometriosis and indicates a severe form of disease. So look here, this is the picture of the kissing ovaries which are stuck behind the uterus. Again, the uterus looks a bulky and endometriotic, and that was the picture, previous picture was of the sonography picture of the same thing. Now, after covering the ovaries, let's move on to the uterus. How does the uterus look like in endometriosis? Due to involvement of uterosacral leading to adhesion, endometriosis tends to cause retroflexion, retroversion of uterus, and this should alert us to the possibility of involvement of POD and need for further assessment. So this is a uterus in endometriosis, which is retroverted and retroflexed uterus, and altered version, if we can see in this clipping, altered version of uterus due to adhesions in POD. So uterus is altered and it is stuck behind. Now you can find the nodules or implants also. They vary in size from few millimeter to few centimeter and are superficial to deep. So these are the nodules which can be picked up by the ultrasound, and nodules in the uterosacral. White line denotes the uterosacral, and you can see the nodules in the uterosacral. Nowadays, we have good endometriotic scan available, and there are places where we can do the good endometriotic scan done. Now, deep invasive endometriosis, the definition is infiltration of endometriotic nodule more than 5 millimeter. It can be located in rectosigmoid, uterosacral, rectovaginal septum, vagina, and bladder. So these are the different locations of dye. And bowel nodule, you can pick up bowel nodule, as I said, that by sliding signs. Usually it involves anterior rectum, rectosigmoid junction, or the sigmoid colon, and typically hypoechoic or isoechoic nodules with tender on palpation. There can be bladder nodule. You can see here, this is a picture, this is a bladder, and you can see there's a bladder endometriosis. This hypo or isoechoic lesion, again, small internal anechoic cystic areas, seen in approximately 30% of the nodule. Look at in this section, you can see this is the bladder wall, and this is the endometriosis, which can be seen projecting into the bladder. Now, why it is important to diagnose bladder endometriosis? Because it mimics recurrent cystitis with dysuria, urgency, frequency, suprapubic pain, and incontinence. And macroscopic hematuria is relatively rare. It occurs in 1 to 4% of women with laparoscopic diagnosis of endometriosis. Diagnosis is often delayed and not considered at all. This is one case which I know that is really disheartening to see. 22-year-old girl, because she had ureteric endometriosis which remained undiagnosed, and that led to hydronephrosis, and she had a non-functioning kidney, and we had to do nephrectomy. So I urge that we should not really leave endometriosis undiagnosed, and especially bladder endometriosis and ureteric involvement in endometriosis, and no one should really be leading or needing this kind of surgery in the modern times, especially when we have good investigation modalities available. So next is endometriosis can happen anywhere. It can be found in myomectomy scar, and ovarian mobility needs to be checked. How you check it? Apply pressure with transvaginal probe to assess whether ovaries fixed to the uterus medially or pelvic sidewall laterally. Note any indication or site-specific pain, and this is how you chase for the uterine mobility. Mobility in the pelvic structures. So this is the sliding sign. What happens? Assess, use a pressure. Uterus should slide anterior to the rectum, and use free hand over abdomen to assess movement of the uterine fundus. So this can be easily, you can see a little fluid here, so you know that it is not stuck. So it is very, very important to know if the positive sliding sign is there. Follow the black line to assess the rectum. And this is absent sliding sign, means everything moves together. They go together, uterus, your pouch of Douglas, and rectum, and the ovary. So this is absent sliding sign, and this is sign of deep invasive endometriosis. So follow the black line, identify the rectum, put the pressure, and see. Now, this is, you do find adhesions, and this is a typical question mark sign. Fundus of the uterus is pulled by adhesions, and this is known as the Fleppig cell sign. And this is a question mark sign, and this is adhesions in the POD. You can see the same thing. Now, checklist in endometriosis, check for the uterine mobility and endometriosis, ovaries, endometrioma and mobility, mobility of anterior compartment, mobility of posterior compartment, bladder, bowel endometriosis, and hydronephrosis. MRI, it helps in assessing area inaccessible to laparoscopy. In our practice, we send for MRI if patient has been previously operated and endometriosis, recurrence of endometriosis, or we are suspecting deep invasive endometriosis along with a deep involvement of the other structures, and just to be on the safer side. And this is an international terminology for endometriosis, IDEA, and it's a very good paper by Matthew Lenardi et al., in which they have explained detailed analysis of endometriosis on ultrasound. So if anyone wants to refer, they can click a picture and go through this. It's a very good article. So just take home message, transvaginal ultrasound is accurate at assessing endometriomas. Severity of symptom does not correlate with extent of disease. Identifying an endometrioma, likely that there is further site of pelvic endometriosis. Kissing ovaries associated with extensive pelvic adhesion. Adenomyosis is usually underreported. Assessment of pelvic mobility can indicate adhesions. Just to summarize, imaging modalities, with current improved high resolution scanning, it is now possible to diagnose most of the endometriotic lesion, and transvaginal is accurate, but do a transabdominal scan as well, especially when there is an endometrioma, ovarian endometrioma you are seeing, and refer endometriotics it to endometriotic center to ensure safer management. With this, I invite all of you, and please circulate this in your association and societies, to FOXY Vice President's Conference, which is in Indore on 8th, 9th, and 10th May. So please come over and bring your friends also. We'll have a good time. And thank you very much. With this, I request you to support and vote for me in forthcoming FOXY elections for my president candidate. Thank you so much. I'll be with you, for you, and by your side.
Thank you, madam. May I request Dr. Arpita ma'am? Arpita ma'am, will you give your concluding remarks?
Hello.
Yes, ma'am, we can hear you.
Yeah, it was really a wonderful talk by Madam Archana Baser. Similar was a talk in Gayaji also. And for this, I will just like to conclude that it was really a very informative paper. And when we are seeing a patient, we should be endometriosis minded. Like in ectopic pregnancy, if you are ectopic minded, you will diagnose. My professor, he used to do pelvic examination and guess scolagra endometriosis. And for endometriosis, we should make up our mind after pelvic examination also. And nowadays, the best modality for diagnosis is ultrasonography. And we should not go for any laparoscopic, laparoscopy should not be used for this diagnosis of endometriosis. And thank you, madam. Thank you for your very, very informative talk.
Thank you, ma'am. Thank you. And we are having beautiful special guest with us, Dr. Anu Chawla. Can we introduce her, ma'am, now? Can we invite her? Yeah,
Yes,
I think it was visible.
Anu has joined
Can
from...
we give her CV, please?
And that's fine. I want to thank Dr. Archana and to all of your team and my very good friend Dr. Brijbala, together as chairpersons in the last term. So I heard the talk, Dr. Baser, and we need definitely more academically oriented people to lead our organization. So I wish you very good luck and hello to all the other learned colleagues that I can see. Thank you very much.
Thank you, Anu, for joining in. I'm really pleased to have you here. In spite of the time zone difference, you could connect with us. And it's an endometriosis month, and we are doing this webinar, this CME on endometriosis. And it is really, really nice that as an endometriosis chairperson of FOXY, you could join in. Thank you so much.
And
Thank
the
you.
beautiful line in your CV, Anu, that the endometriosis not lies in brain, it's in pelvis. So thank you for joining, and it was pleasure to have you on board. Yourself as committee chair of FOXY. Thank you so much.
Thank you, Dr. Tiwari.
Rudri?
Yes, ma'am. Thank you so much, ma'am. Thank you, Anu, ma'am. Thank you, Brijwala, ma'am. And special thanks to Basir, ma'am, for the wonderful and crisp talk. So let me take ahead the scientific session. And for this, I would request our chairperson, if Rakhi ma'am is there or not, then I would request Dr. Arpita Gandhi ma'am to kindly introduce our next speaker, Dr. Jyoti Malik ma'am. Can we have the CV of Dr. Jyoti ma'am, please? Ma'am, I think Rakhi ma'am has not joined yet. She is in OT due to some emergency. So can I request Arpita ma'am, if she is comfortable, then kindly introduce our next speaker, Dr. Jyoti ma'am.
We can go ahead without the introduction.
Yeah,
No, ma'am.
Jyoti, you are a well-known figure in OBGY, in infertility. And may I take the privilege to introduce Dr. Jyoti? She is very good friend of ours, and she is chairperson Haryana chapter of SR, vice president Haryana OBGY, and so many posts she is holding, and so many achievements she is having in her credit. Women Transforming Indian Award 2024 by Six Sigma Healthcare, Women Achiever Award, and so many things. And she just completed her OPU and she joined from her lab only. So over to you, Dr. Jyoti.
Thank you. Thank you so much. Thank you, learned faculty here, and many. I could partly hear Dr. Archana Baser ma'am's talk, and that was fantastic. And thank you, Dr. Archana and Dr. Brajwala, for giving me the opportunity. I would like to now share my screen here. And it was wonderful to have Dr. Anu there. She's a great friend, and she always makes a point to at least be there whenever her name is there in any program. So thank you so much, Dr. Anu there.
Yes,
And,
I'm very pleased to see you. I'll actually stay back and listen to your lecture. Thank you.
Yeah, my pleasure. Thank you so much. So moving on to this update for endometriosis management position statement, I would talk on this, and I have taken the complete talk from this particular Journal of Endometriosis and Disorders, Volume 6, June 2024. Now, we all understand, and even the chairpersons have said that endometriosis, the incidence is increasing, and it is the diagnostic approaches that have evolved, especially the ultrasound, that has made our diagnosis much easier and simpler. And but still, it has a complex pathogenesis, and it has multifactorial risk factors. The most common symptom being dysmenorrhea and infertility, which has such a negative effect on the quality of a woman's life, and therefore we need to make an accurate diagnosis so that we can give a rational and a cost-effective management. Now, it is often underdiagnosed, and normally we believe that, okay, we need to do a surgical and a histological confirmation to make the diagnosis. And we always have this misconception that the menstrual pain is physiological And also because the pelvic pain has multiple causes, the diagnosis remains uncertain, and hence there is a long delay in diagnosing before, in spite of repeated consultations. So, what is the role of the clinical history in this era in the modern diagnosis? So, clinical history, there are also the genetic and the epigenetic factors involved in endometriosis. So, always it is a good idea to have a family history and ask specifically about the first degree relatives as a strong familial clustering is observed. There is a such heritable disposition as well. Now, the genome-wide association studies have revealed that it is a polygenic disease with a multifactorial inheritance, and it has a co-occurrence with endocrine, inflammatory, pain, and immune-related traits. So there are epigenetic alterations which lead on to endometriosis. There is abnormal methylation patterns in the estrogen receptor beta, the progesterone receptors, the steroidogenic factors, COXA10 genes, and the GATA genes. And all of these epigenetic alterations contribute to the progesterone resistance and the altered receptivity. Early life influences also have a significant role, and all this intrauterine and the neonatal programming, the prematurity, IUGR, the early formula feeding, all this can sometimes lead on to endometriosis. So it has is the early life influences also do matter, and sometimes a history of IUGR in the girl, in the baby, can make us correlate. Okay, she might be having endometriosis. There is also a hormonal association, a genetic predisposition linked to lower testosterone levels, and the new invasive, non-invasive biomarkers are emerging, the salivary miRNAs, the circulating blood miRNAs, but they have not yet standardized. In the history, especially in the adolescence, menstrual history and the age at a menarche, early age, this leads to an increased lifetime estrogen exposure. So there are recognized epidemiological risk factors associated. The menstrual pattern, the severe dysmenorrhea, heavy bleeding, and sometimes the possibly uterine malformations can lead on to increased risk of endometriosis. So the red flags in adolescence are the severe dysmenorrhea, which interferes with the school attendance, which limits her sports activities, affects her social life, and she needs to go repeatedly to a doctor for her medical consultations. And all this may indicate an early onset of endometriosis. So whenever we have such a girl coming to us repeatedly in the OPDs with all these symptoms of severe dysmenorrhea, they should ring a bell in our mind that, okay, we might be dealing with a girl who has some bit of endometriosis somewhere. Now, in the treatment history also, when we take, there is a strong clinical suspicion if there is a failure of NSAIDs, or we need a early or a repeated prescription of combined oral contraceptives, or progestins is there with her, or she needs a hormonal therapy due to severe pain. So all these are suspicious factors which we need to take in our history, and we should keep like it is like a puzzle where we keep adding the zigzag in that puzzles. The adolescent risk factors which are associated with later development of endometriosis, low BMI, eating disorders, intense physical activity, a history of physical abuse, and all of them suggest an early life vulnerability. The environmental exposure to EDCs, it may also influence the disease development, the dioxins, BPAs, phthalates. Not only this, there is associated inflammatory conditions which normally which are frequently reported, like migraine, a chronic inflammatory bowel disease, recurrent cystitis, vulvodynias, and also systemic autoimmune diseases which in the history can sort of make the association with endometriosis. So we should also ask all these history, if there is history of autoimmune disease, arthritis, SLE, Sjogren syndrome, scleroderma, multiple sclerosis, autoimmune thyroiditis. So it is not only endometriosis. A lot needs to be found out in the history, and it has a very significant role in the diagnosis. A previous surgical history of abdominal surgery, any appendectomy, history of previous pelvic surgery for chronic lower abdominal pain. So all these in endometriosis, when we are evaluating a patient, either an adolescent or adult with severe cramps, which interferes with her daily activities, which do not respond promptly to first like oral analgesics, and she needs COC, we should think of endometriosis. The clinical steps. In the clinical evaluation, after a detailed history, one should assess the symptoms, do a thorough physical examination. In the symptoms, the gynec symptoms are dysmenorrhea, non-cyclic pelvic pain, or deep dyspareunia or infertility. And the non-gynec symptoms are dyschezia, dysuria, rectal bleeding, hematuria, shoulder pain, sciatica. And also one should go in for the scoring, the symptom severity. The endometriosis is very likely if the dysmenorrhea VAS is more than 6, if their deep dyspareunia VAS is more than 3. So in the gynec examination, again, as one of our chairperson ma'am said, our senior people can, even on examination, they can suspect and can diagnose endometriosis, and therefore after a detailed history, a proper gynec examination is a must in all the cases where we are wanting to understand whether she has endometriosis. Deep nodules, pain trigger points, tender thickening of the uterosacrals, adnexal masses, fixed retroverted uterus, as Archana ma'am showed in her ultrasound, the sliding sign and all that we can assess on the later in the on the sonography, a painful uterine mobilization or the visible vaginal lesions, and a structured symptom assessment with a targeted pelvic examination significantly improves the clinical suspicion and the diagnosis of endometriosis. Role of imaging, we have heard this beautiful lecture, and we have the two main modalities are TVS ultrasound and the MRI. And according to this IDEA group, the International Deep Endometriosis Analysis Group, assessment should include everything of the ovarian endometrioma, not only that, the deep endometriosis and the adhesions. And one should do a compartmental evaluation of the anterior compartment, the bladder ureters, and the posterior compartment, the bowel, uterosacral, rectovaginal septum, pouch of Douglas. MRI only when the ultrasound is inconclusive or when we are suspecting an extrapelvic disease, but it requires experienced radiologist. And MR and TVS, if performed by experts, have comparable accuracy. Therefore, TVS ultrasound, being dynamic, rapid, cost-effective, is well accepted and should be the first line in medical and history. After doing a proper physical examination, one should go ahead with the imaging and preferably the transvaginal ultrasound. Imaging are reliable methods to diagnose endometriosis so as we can start the treatment, and therefore there is no longer need to perform laparoscopy just to confirm and stage the this is important point one should get from this after we have gone through these slides. So no need of surgery to particularly diagnose endometriosis. Now the depends on the symptom, whether there's pain, infertility, the patient factors, her age, ovarian reserve, her reproductive plans, and the type of disease characteristic, the lesion phenotype. That means ovarian endometrioma or is a DIE or there is associated adenomyosis. Medical or the surgical management, which one depends on what we are dealing with, if it is infertility or it is the pain. The rationale behind this is that it is a estrogen dependent and a progesterone resistant are the pathogenesis for it. So we need to suppress menstruation, inhibit the hypothalamic where it is induced pseudodesiccation. Possible, it could be progesterone only pills or yes, combined doses. Has a limited duration, GnRH agonists, but they require monitoring, and a recently introduced oral GnRH antagonist, preferably with the add-back therapy. And adjuvant therapy, the NSAIDs, can be given to suppress the pain. Now, surgical management, if there is intolerance to medical therapy or there is the specifically, we need to do surgery. If there are three things, if there is a suspicious endometrioma, we are suspecting malignancy, number one. If there is intestinal subocclusion, that means there is ileo or ileocecal deep endometriosis. And the third that Dr. Archana showed, a ureteral involvement with a hydronephrosis. So all these three things need immediate surgery, and otherwise there is not much need, or if there is severe pain, that is, I think, fourth indication. We need to consider the major complications in surgery, but it requires also a multidisciplinary team because a complete excision should be done. Fertility considerations, particularly important if it is a reproductive age woman. Fertility preservation should be thought of when there is ovarian endometriosis and there is a high risk of future infertility. And if immediately the pregnancy is not desired, then one may add post-op hormonal therapy because it reduces the risk of recurrence. A holistic multidisciplinary care needs to be done, and a shared decision making involving the patient and her functional goal setting with a long-term planning should be done. Infertility, surgery versus ART, surgery, the key evidence suggests that ART outcomes are comparable to infertility from other causes. The pregnancy rates are not significantly influenced by the endometriosis phenotype, and both surgery and ART offer similar overall chances of pregnancy. Surgery has certain advantages because there is a possibility of spontaneous conception following surgery. Simultaneously, the pain is being treated and the pelvic anatomy is being restored. Advantages of ART is that excellent pregnancy rates without mandatory prior removal of ovarian endometrioma or deep endometriosis is done, and it avoids potential ovarian reserve damage from the surgery. Now, factors which influence the choice are the patient factors, her age, duration of infertility, the previous endometriosis surgery, the tolerance to medical therapy, and her willingness to accept surgical risk. The disease factors, the presence of ovarian endometriomas, DIEs, and adenomyosis, the suspicion of malignancy, and the additional infertility factors if there are male factor, tubal factor, or hydrosalpinx. Now, when ART should be preferred, if there is a reduced reserve, advanced maternal age, long-standing infertility, presence of other infertility factors, recurrent disease after prior surgery, or coexisting adenomyosis. Specific consideration, GnRH agonist suppression, ovarian suppression, only in selected cases. Embryo transfer should be freeze-all, it should be deferred, and it should be a freeze-all policy following later transfer in the next cycles, or especially in cases of endometriosis. Special situations need to be tackled. If there is hydrosalpinx, one needs to do a lap salpingectomy. Large ovarian or endometriomas, ultrasound guided or laparoscopic drainage, it is case dependent. Management depends if there is immediate desire for surgery for pregnancy, then either ART or surgery, considering fertility preservation. And if depending on that, if not immediately desiring pregnancy, then one goes for medical treatment and do a long-term follow-up in such cases. And if for pregnancy, one has to go in for either of the two. So the final principles need to be taken care of. That means we have to go along. It has to be patient-centric. Endometriosis is a complex estrogen-dependent inflammatory disease with a significant impact on the pain, fertility, and the quality of life. Early clinical suspicion is critical, especially in adolescents with severe dysmenorrhea, unresponsive to NSAIDs. The modern diagnosis is clinical plus imaging-based. Diagnostic laparoscopy is no longer required solely for diagnosis. Management has to be individualized based on her pain, on her primary symptom, whether it's pain or it is infertility, her age, ovarian reserve, her reproductive plans, and her disease phenotype. Hormonal therapy is the first line for pain. Surgery should be carefully timed and performed once in specialized centers, balancing the symptom relief with ovarian reserve preservation. For infertility, ART and surgery offer comparable outcomes. Treatment choice depends on the ovarian reserve, the patient priorities. Fertility preservation should be discussed early, especially before ovarian surgery, and the optimal care requires a multidisciplinary, personalized, and shared decision-making approach. So thank you so much. Open to any questions. Thank you.
Thank you, Dr. Jyoti. It was excellent talk. May I request Dr. Arpita ma'am? Ma'am, are you available for your expert comment?
Yeah, it was really, Dr. Jyoti, it was really a very, very informative talk. And I have learned many things from this paper. Really, really thank you. And now I will call upon Dr. Pratik Tambe, sir. Has he joined? Dr. Pratik Tambe?
Yes, madam. Dr. Pratik is visible here.
Welcome, Dr. Pratik. His CV is so long.
I think we stopped
Yes, so
reading
many
this
credential, madam. Dr. Pratik is currently ICOG secretary and so many positions he is having. And thank you, Dr. Pratik. In spite of having so much busy schedule, you accepted this MPSR initiative.
Not at all.
Go
It's
ahead,
wonderful
please.
to be here. If I may be allowed to share my screen, because we can't have more than one person sharing simultaneously. So thank you very much to the MPSR team led by Dr. Archana Paser, Dr. Brajbala Tiwari. And let me also thank the other people who are working behind the scenes, Dr. Manila Kaushal, Dr. Deepti Gupta, Kalyani Shrimali, and Dr. Rudriya Karwal, who is here. They've all been working very hard to ensure that this annual MPSR CME goes off well without a hitch. I'm here to speak to you about stimulation protocols in endometriosis associated infertility, and hopefully I'll be able to finish in 20 minutes. And it's going to be a long talk. It's going to be a complicated talk, but I hope that at the end of the entire talk, you will have some good take home messages and practical approaches which you will be able to implement in your daily clinical practice. One thing you can't hide is when you're crippled inside. And I'm sure that John Lennon was talking about a broken heart, but it is so very applicable also in women with endometriosis. It is not pertinent to question whether this topic is clinically relevant after you've had two excellent talks by my preceding speakers, Dr. Archana Baser and Dr. Jyoti Malik, on various different aspects of endometriosis. This is the most recent ESHRE guideline, which was published in 2022. We look forward to it being updated very soon, and that will give us a little more practical take home messages once it is updated, hopefully in this year or the next. This is a very old, nice guideline for those of us who like to follow RCOG or NICE guidelines. This is published way back in 2017. Probably the updated version also will be out soon. ASRM has some practice committee recommendations on endometriosis and infertility, and they specifically say that medical treatment for endometriosis is effective in relieving pain, and it is the first choice for adolescent endometriosis, chronic pain, and recurrence. And why is this slide here? This slide is here because often when I travel to the interiors, to the small towns and villages, people often feel that when they give medical management of endometriosis, whichever medications they might give, the patient should automatically conceive on her own because we are suppressed the disease, right? She should conceive on her own, left to her own devices. Unfortunately, that is not the case. When we talk about the practical management pathways, we are aware, and this has been highlighted very well in social media as well as lay media over the past month, which is the Endometriosis Awareness Month, that most women will wait for at least 7 years to receive a proper diagnosis of endometriosis, and this is in Western countries. This is not just in India. We don't have equivalent figures for India, but I'm pretty sure they are going to be similar or there is going to be an even greater delay. I've structured this presentation in the following format. We talk about the goals of therapy, we talk about informed treatment choices, strategic planning, shared decision making, and management algorithm, all of which has been covered to some extent in Dr. Jyoti's talk. So I'll skip past those boring slides and get on with the main meat and bones of my talk. Your goals are going to vary with the stage of the disease. That is well known to all of us. And specifically, if you're going to talk about medical management, then you're going to try and control pain, improve fertility directly or indirectly, enhance the quality of the life of the patient, and prevent recurrence. But as I said, we are here primarily to talk about endometriosis associated infertility. And the simple take home message for those of you who don't practice IVF is if you give medical management for infertility, for endometriosis, the woman is not going to ovulate on her own. And if she doesn't ovulate, obviously, she is not going to get pregnant. So both are two different branches of the treatment pathways. Having said that, there are multiple reasons why endometriosis is associated with infertility. You're going to have uterine and ovarian dysfunction. You're going to have peritoneal inflammation because of a lot of cytokines, prostaglandins, inflammatory markers, which are going to be elevated. You're going to have activated macrophages, which are much more. And once you cross all that, you're going to find that your immune mechanisms, which are responsible for embryo implantation, are all completely fired. Specifically, glycodyline A, osteopontin, and hoxaten are all going to be suppressed. And that is going to result in poor embryo implantation. We will come to that in just 1 or 2 minutes. So medical management precludes fertility, and the other take home message for today is that fast track treatments will always yield better results. Now, where do you fast track? When do you fast track? That is something which we need to learn. We need to understand when to intervene and when to leave well enough alone. How do we treat subfertility, which is associated with stage 1 and stage 2 disease? I've just put this in as a primer. This is not the focus of the talk. The most important learning points here are that sometimes endometriosis is just an incidental finding at what we call, in inverted commas, diagnostic hysterosalpingometry. Now, this is a concept which we had maybe 15, 20 years back. We used to do diagnostic scopies. In clinical practice today, we hardly ever do what is called as a diagnostic hysterolaparoscopy. It is almost always a targeted scopy, which is going to be an operative scopy with a see and treat approach. If you see that there are endometriotic implants, you do your bipolar fulguration, and ideally you would like to excise them, except of course when they are directly overlying the ureters, where you must use an abundance of caution. And after that, you have two options in front of you. Either you can give active fertility treatment, or you can just wait and watch and hope and pray, fingers and toes crossed, that the patient is going to conceive, as I said, left to her own devices. I'm not going to talk about EFI and endometriosis fertility index because I'm sure that it must have been covered previously. I'm going to switch off my video because there's a power failure here. Fortunately, the laptop is charged, so we can still go ahead with the talk. So this is the scoring system, and this is the chart which all of us are familiar with. The reason this is here is because this gives us a very good way of prognosticating for the patient and counseling the couple as to what are her chances of conceiving after surgery. Obviously, if you have somebody who has an EFI which is less than 5, then the chances that she will conceive on her own after, say, 6, 12, or 18 months are going to be abysmal. And these patients obviously are going to require fast track treatment. On the other hand, if you have somebody whose EFI is 6, 8, or 10, then you know that she's going to do well. Probably you would like to interfere less in this case, and you would give her at least a reasonable amount of time for her to try on her own. So, which are the patients that you would fast track to ART? That is where your EFI is going to be less than 5. And there, this is evidence based, this is validated in patients, and this EFI scoring actually came out in 2009. I have the original paper published in 14 Sterile, which I just showed you. And in case you're interested, I can share it with you. Just email me, I'll be happy to send you. Couple of slides about dydrogesterone because it has come back with a vengeance in the past 2-3 years. There are at least 50 or 60 different pharma companies which are shoving this down our throats and hoping that we shove it down our patients' throats as well. But there is a very good evidence-based reason why you would recommend dydrogesterone specifically in stage 1, stage 2 disease. There are multiple trials which show that patients have very good pain relief, especially when they have dydrogesterone administered post surgery, when they've undergone surgery for stage 1, stage 2 disease. And you will find that the immunomodulation, which is deficient in these patients, owing to various reasons, like we just said a couple of slides ago, this is all going to be potentiated with the aid of dydrogesterone, which is well known to be an immunomodulator. We are aware of its efficacy, especially in patients with RIF and RPL. Similarly, the chronic inflammation which occurs, the peritoneal surface inflammation which occurs in these women with high amounts of prostaglandins, cytokines, TNF alpha, etc., as you can see in this slide, are all going to be potentiated and suppressed by dydrogesterone. So you can either use it in a continuous regimen or you can use it in a cyclical regimen. It does not prevent ovulation from occurring, and if pregnancy does occur, it helps in the embryo implantation and the first 6 weeks, which is very important for organogenesis and embryogenesis. So this is how dydrogesterone works in these patients, but is it evidence-based? And you will find that there are plenty of good studies which say that as far as pain relief is concerned, dydrogesterone works well in stage 1, stage 2 disease. There's good compliance and acceptance, both on the part of the clinician as well as the patient. And if you look at the forest plots, if you look at the meta-analysis, pregnancy rates are quite good in stage 1, stage 2 disease, where you go in for the, in inverted commas, wait and watch approach for, say, 2 or 3 months. And then later on, if that doesn't succeed, then you would actively intervene. And what would be the active intervention there? If it is just stage 1, stage 2 disease, maybe we would like to do an IUI. You don't want to offer these patients IVF directly and push them down into that factory assembly line approach, which we seem to have, unfortunately, today. If you look at the meta-analysis and the recent papers which are published, this is one such paper in 2017, they said that women with endometriosis have a success rate with IUI of approximately 9.9, that is 10%, in the best of hands. So you need to have realistic expectations. You need to counsel the couples well. And of course, we are only talking about those patients where there are novel tubo-ovarian relationships. There are a good number of antral follicle count. They don't have a very compromised AMH. And you are aware that there are no other concomitant factors like a male factor or a tubal factor in these patients. Then you would consider offering IUI to these patients. The realistic success rates with IVF, unfortunately, are not very high. And this is from the SART registry, especially if you see women who are more than 35 years of age, you get success rates of around 30%. At obviously, with the age more than 40, it's going to be quite low. It's going to be almost 10 or 11%. And therefore, if it's an elderly couple, long duration of infertility, stage 3, stage 4 disease, previously failed basic treatment like timed intercourse or IUI, then obviously you're going to fast track these patients to IVF. Which brings us to the $1 million question. You've decided that you're going to offer IVF. Patient is agreed. Couple is happy to spend the money. Now, what is the stimulation protocol of choice? Now, this is something which has troubled us for quite some time. There have been differing schools of thought. There's one school of thought which says that you go with the long agonist protocol because it gives you good quality oocytes, it gives you the best success rates, it gives you excellent embryos. And there's another school of thought that says that maybe because these women are poor responders, they're only going to give you 1, 2, or 3 oocytes at most. Why increase the treatment burden? Why stimulate them for such a long period of time? Just do a simple GnRH antagonist protocol and you should be absolutely fine. And there are multiple papers to this effect. There's evidence on both sides of the divide. And let's examine what the evidence says. So this is one such paper which is published in 2023. And this looks at the GnRH antagonist protocol versus the long protocol versus the ultra long protocol. And what they've said is that the GnRH antagonist protocol can be combined with embryo freezing to achieve exactly the same results as the ultra long protocol. There isn't much difference in terms of clinical pregnancy rate and live birth rate if you use the antagonist protocol. There may not be any significant advantage to using the long agonist protocol. Another question that we need to consider is whether when we stimulate the patient with gonadotropins for ART, is the disease itself, is endometriosis itself going to flare up? Is it going to lead to worsening of the disease or what we call upstaging of the disease? Now, we are familiar with this concept in oncology, where you know that if you give certain treatments, it's possible that there may be dissemination of your metastatic cells. And as we know, endometriosis functions like a locally invasive cancer. And to this, we have multiple papers. This is one such systematic review and meta-analysis which I found published in 2019 February. And they say that IVF does not worsen endometriosis associated pain. It does not increase the risk of recurrence. The impact of IVF on ovarian endometriomas is mild, but this is low quality evidence. IUI may actually increase the risk of endometriotic recurrence. And that's the only treatment which may actually lead to upstaging of the disease. IVF doesn't seem to do that. And deep invasive endometriosis may progress, but again, this is low quality evidence. So they concluded by saying that the available evidence generally says that aggressive clinical approach is not required. For example, prophylactic surgery before you do ART does not necessarily require is not necessarily required. And again, your stimulation protocols are not going to lead to disease progression or recurrence. Which brings us very nicely to the question of how do we manage subfertility in stage 3, stage 4 disease. We covered this briefly, but I found a couple of good papers for this. And this is one such paper in 2023, which is the largest meta-analysis of nearly 18,000 cycles. This is the largest published body of evidence on endometriosis. 17 studies, 17,500 plus IVF cycles. And what they said is that these women have a lower mean number of oocytes retrieved when they have endometriosis. The duration of stimulation is longer. Number of oocytes retrieved is lesser, but the mature oocytes are exactly the same as age-matched controls. Rate of unexpected poor response is obviously going to be higher in these women because they have endometriosis. And this higher rate of unexpected poor responders persisted specifically for women who had undergone surgery for their disease prior to stimulation, which means that no matter how good a surgeon I am, I may be the best endometriosis surgeon operating in the best unit, in the best environment, in a center of excellence, but the impact on the ovarian reserve is definitely there. And it is incumbent on us to ensure that we are counseling couples before putting them up for surgery, that this impact is very real. So, what are the challenges and hurdles that you will face as an ART clinician when you are treating women and you are stimulating them for an IVF cycle? We know that these women will have premature ovarian insufficiency, especially if they've previously been operated. They're going to require a higher dose of gonadotropins, a longer duration of stimulation. The procedures themselves, oocyte retrieval and embryo transfer, both are going to be difficult, especially if it is stage 3, stage 4 disease. If she has deep infiltrating endometriosis, she has nodules, if she has endometrioma, she has kissing ovaries. It's going to be technically much more difficult. It's not for somebody who is faint hearted or who has not done these difficult procedures earlier. You are obviously going to have a lesser number of
चाहो तो तुम बाद में
oocyte.
ज्वाइन हो सकते
Both
हो, we
your
can just do it,
FOI
पहले तो मास्क
and
निकालने
your
के
FORT are going to be lower. You're going to find that your oocyte quality is poorer. You are also going to see that your fertilization rates are lesser as compared to age-matched controls. And most importantly, you're going to have lesser number of top quality, good blasts, which will be able to transfer in these patients. And if you've managed to cross all those hurdles, remember we said that the most important markers like osteopontin, oxaten, glycodyline, all of them are going to be compromised, which means your endometrial receptivity is going to be very sad. Now, this is a very bleak picture, but how does it actually translate into clinical practice? And I have another paper here published in 2024, and they said that when you look at the clinical pregnancy rates, it doesn't really make a difference as to which protocol you use. Just use good quality gonadotropins, and you will usually be able to get at least a few good quality embryos which will be able to use for the transfer. Last 2 or 3 slides, if you have an endometrioma, and I'm pretty sure this is going to be tackled in the panel subsequently, so I'll just quickly go over these. I have already been speaking for 17 minutes and 30 seconds, so I'll finish in 2.5 minutes now, because I don't want to speak longer than 20 minutes. These women who have endometrioma, unless it is 4 centimeters or more, actually recommends that surgery is not really required, especially if they have pain. That's the only indication for surgery in today's world. Women who have adenomyosis or adenomyoma, how do you manage? Here again, this is what I call a perfect storm. You're going to have poor quality gametes, compromised receptivity, difficult embryo transfer because of infiltrating nodules. Sometimes you may even require to give anesthesia to these patients because the entire canal is completely distorted. You will not be able to achieve a clean transfer in these patients sometimes unless you have good relaxation. Again, in these patients, how many embryos you get, what is the quality of embryos, your mileage is going to vary from patient to patient. And ultimately, when you have your endometrial volume, which is assessed serially, and you've managed to suppress the disease significantly, only then would you choose to do a staged embryo transfer following the segmentation protocol. And finally, of course, when everything else fails, you don't have good quality embryos, or you land up with poor quality eggs, and consistently you're not getting results, then oocyte donation may be the only way out. Does mitochondrial rejuvenation have a role to play in these women because they are poor responders? That's a valid question. All of us give antioxidants, and most of us would give what is their own preferred antioxidant. There are no meta-analysis or systematic reviews which favor one particular antioxidant over the other, but mitochondrial rejuvenation does have a role to play in some of these patients who function like poor responders. Is fertility preservation to be recommended? A strong yes, not just 100%, but 200%. And we are all familiar with Diana Hayden, who had endometriosis. And thanks to Masako Oyama's beautiful vitrification protocol, she was able to have multiple rounds of IVF and multiple children. So to conclude, ladies and gentlemen, I'm going to say a few key practice points which are important for all of us to understand. Endometriosis associated infertility presents a lot of challenges which many of us don't realize when we start out in clinical practice. Irrespective of what is the stage of the disease, you're going to have compromised results. The evidence will tell you that the number of eggs will be the same, the number of embryos will be the same. But those of us who have lost all our hair practicing since 20-25 years, we know the harsh reality that in clinical practice, in Indian patients, because they present quite late, they come to us with stage 3, stage 4 disease. The number of oocytes is less, the quality is poorer, blastulation rates are not acceptable in many of these patients. And often we end up doing a day 3 transfer simply because we're not confident whether those embryos will reach day 5. Therefore, good counseling, realistic expectation, and ensure that when all else fails, you fast track them to oocyte donation. That is the best way forward. As far as protocols are concerned, some of us like the long Econis protocol because it gives us a very nice synchronized cohort, but the evidence says that the results are not significantly better. Thank you for a patient hearing, and I wish Dr. Archana Basir all the very best in her quest to be Foxy President. Thank you for inviting me.
Thank you, Pratik. Thank you. It was an excellent talk with lot of, insights plus updates and everything. I think we learned a lot from your lecture. I think over to Rocky and Dr. Arpita for comments. I can see Dr. Ramni has also joined. Hello, Dr.
May I
Ramni.
request Dr. Rakhi to
Dr.
Dr.
Ajay,
Rakhi.
hello,
Her
Dr.
video
Ajay
is
has
off.
also joined from Chandigarh.
I think Dr. Rakhi had joined, but
Some technical issues, probably.
Yeah, that happens. But I mean, it was mesmerizing the way you have handled each and every step. Like, in endometriosis, what matter you do, the number of oocytes is not going to change, number of embryos is not going to change. So have a real expectations. And that was the take-home message for me when counseling endometriosis.
so shall we move forward, ma'am, for the next session?
I think yes, Dr. Ramani is taking the next lecture, or Dr. Ajay. I'm not sure.
Shall we invite Dr. Bhavya? Dr. Rudri, will you invite Dr. Bhavya? She will go ahead with the next.
Yes,
We are
ma'am.
having chairperson Dr. Sonia,
Here,
Dr.
ma'am.
Jagruti. Yeah. Dr.
Well,
Bhavya, over to you.
Bhavya, to take the session
Yes, ma'am.
further, we
Yes,
introduce
I'm here.
that we can move ahead. Dr. Bhavya, over to you.
Yes. Thank you. Thank you so much, Dr. Rudri. And thanks to all the speakers for such beautiful sessions. Thank you to Tambe sir also. Rakhi ma'am has joined. Ma'am is not able to turn on her camera. But anyway, so moving to the next session, Bhakti, can you please put on the CVs? Yes. So calling the chairperson, I'm inviting Dr. Sonia Mandappa. She's Associate Professor at International Academy of Reproductive Sciences, Mysore. She's Secretary KCOG, Academic Wing of KSOGA, and President-elect MOGS 2026. She's also Vice President MOGS 25 to 26. Ma'am has been awarded multiple awards, including Star Performer Awards, India version 2020, and Nagrika Seva Chetna Award, Bharatiya Sanskrit Vikas Vedike. We welcome you, ma'am.
Thank you, madam. Thanks for that.
The next chairperson is Dr. Jagruti Ghosh, ma'am.
Hello, good evening.
Bhakti, please slide. Welcoming Dr. Jagruti Ghosh, ma'am. She's Director and Consultant at Joanna Mother and Childcare Hospital, Meera Road. She's also Youth Council Member, AFD 2526, and Special Invitee Managing Counseling Member, MOGS. And she's recipient of Dr. R.T. Pandit Award of MOGS. We welcome you, ma'am. I request the chairpersons to invite our speakers, Dr. Ramani Devi, ma'am, and Dr. Ajay Gawal, sir. Thank you, ma'am.
Thank you. Thank you, madam, for that. And thanking the team, MPSR, Chairperson Dr. Archana, madam, and then in advance wishes to you to climb up the Foxy ladder. And Secretary, Madam Dr. Bajbara Tiwari. We've been doing a lot of environmental committee Foxy work under the leadership of Madam Bajbala. And I think here in this platform, I just take half a minute to just enumerate that. I think Dr. Ramni also will agree with endometriosis is increasingly considered as a disease which is influenced by environmental exposure. The EDCs is altering the estrogen signaling, immune function, and epigenetic pathways, from thereby promoting implantation and persistence of ectopic endometriotic tissues. So I think we'll work towards that also. In this note, when we move further, it's a great honor to introduce a personality who needs no introduction in this virtual platform, Professor Dr. Ramani Devi. She is an awardee, Dr. APJ Abdul Kalam awardee, a distinguished academician, clinician, research
a model to so many of us, we young Foxians, who Madam has made remarkable contributions to the understanding and management of endometriosis. She herself is an editor of Endometriosis Updates, which is published by Endometriosis Society of India, and she's EC member of ASI. We have been hearing Madam continuing her webinars past 1 week, and we make sure that we attend each and every webinar of hers because she's sharing her knowledge and updating the entire fraternity. And we all here celebrate today, this March month, as Endometriosis Awareness Month. Thank you again for the MP ISAR team for this conduct of webinar. Over to you, Madam. It's a privilege to hear and listen to you again.
Thank you, Dr. Sonia, for your nice introduction. Let me share my screen. So first of all, let me congratulate the MP ISAR team for having arranged this wonderful program on endometriosis. And today, this month being a month of endometriosis awareness, I think all of us should initiate the awareness programs, whichever place it is available, so that the women will be benefited to some extent at least. So then there was a article which they had shown that among the general practitioners, they were not even aware of this endometriosis. So when such is the case, I think we need to keep update ourselves in endometriosis, and hence the topic is on updates in endometriosis. I bring you greetings from my beautiful city that is Tiruchirappalli, in the heart of Tamil Nadu, where you can see the beautiful Kaveri and the rock fort, which is the iconic symbol of Tiruchirappalli. And here you see the UNESCO accredited 1000 pillar that is seen in the Srirangam. And here it is a painting that is seen in one of the churches in Italy, where these two young girls, see, she is wearing a chain that is made up of thorns, and you can see the apples and the acorns, and flushes in the face. This denotes the gripping pelvic pain she has, and apples are symbol of fertility, which is very difficult to grow, and the pain she suffers. So by definition, I need not go. It's the presence of endometrial tissue abnormally implanted in the locations other than the uterine cavity. And in adolescence, there is a slight variation. The stroma is much more than the glands, and the implants grow and invade the tissue in their vicinity, causing inflammatory reaction. So my update in endometriosis will be right starting from definition, etiopathogenesis, gut microbiome and endometriosis, classification, diagnosis, medical treatment, surgical treatment, infertility, systemic disease, and conclusion. First, let me say why at all we should have an update. In the past, endometriosis was thought as just a gynecological lesion with a paucity of the data, and diagnosis was confirmed only by laparoscopy, and medical management was only secondary. Removal of the lesion was the priority, and recurrence means it is an incomplete primary surgery. ERT wasn't safe or effective as it is today, and there was no effect. They thought that there was no effect on the ovary. But the current thinking is it is a chronic inflammatory syndrome with richness of data, no need for histological diagnosis. Medical management is the primary one. Preservation of ovarian reserve is the priority. Recurrence means it is presence of this persisting offending factor. And nowadays the ARC is quite safer, more effective. Almost the results are as good as tubal or the male factor. And when you consider the eggs, the oocyte quality and the quantity is quite bad. And they have studies to show that in endometriosis, the decrease in the oocyte is almost 23% every year when compared to 5 or 6% in a non-endometriotic patient. So prevalence is quite high. It is most commonly seen in infertile women, 75% of the women with chronic pelvic pain, and women with dysmenorrhea. And in the recent past, the WHO says that 246 million women suffer from endometriosis globally. And in that, around 50 million women are in India alone, according to Endometriosis Society India data. Then, now coming to the etiopathogenesis, long time we have been taught about the retrograde menstruation, metaplastic theory, then the lymphovascular and iatrogenic theory, and so on, invagination theory. But now we know that there are a lot of newer inventions in the etiopathogenesis, say it a genomic alteration or a epigenetic theory, or even now we have the stem cell theory, which is coming out in a big way. So here, not only the retrograde menstruation, but then how every woman has got a retrograde menstruation, but still only 10 to 15% of the women, they develop endometriosis. That is because of the genetic predisposition and alteration in the immune response and the macrophages that are present in the peritoneal cavity. Instead of producing the factor that is, they have to imbibe the endometriotic tissue that is shed into the peritoneal cavity. What they do is they start producing pro-inflammatory factors, and there is increased elevation of all these interleukins. There is increased production of VEGF, neural growth factor, and then angiogenesis as well as MMPs. All these things will cause binding of this endometriotic tissue into the peritoneal cavity. Then comes, there are lots of these neural growth factors, and they have found out that the number of the percentage of the neural fibers in the endometrium of endometriotic tissue, sensory C nerve fibers, are almost 14-fold increase in the endometrium of endometriotic patients, and that is why we get severe pain. Not only that, even after the removal of the surgical removal of all the tissues, there is the set sensory nerve pathway is there, the nociceptive pathway, nociplastic pathway is there, which is being always kept, and even a small trigger in the pelvic or the perineal region, even after surgery, it can trigger the same amount of pain. Hence, there is some slight modification in the management also. Then, of late, we now know that gut microbiome is the root cause for any disease, and endometriosis is not an exception. This dysbiosis are of the gut. It can lead to immune dysregulation, weakened barrier. There will be leakage of the microbial metabolites and the contamination, which will cause increase in the pro-inflammatory status, and there can be immune suppression, and the retrograde menstruation can lead to this addition of this endometriotic tissue, and again the estrobolome is totally changed, and there is more increased levels of the estrogens when compared to the, and here again there is level of E2 is much more than the E1. Generally the E2 gets metabolized to E1 by the 17 beta alpha hydroxysteroid dehydrogenase enzyme system, which is deficient in endometriosis. So that will lead to piling up of the estradiol, causing estrobolome. So now let us see what is the changes in the classification. The classification of endometriosis right from 1970s, it was basically on the gross appearance, superficial, peritoneal, ovarian, and deep infiltrative endometriosis. They have poor reproducibility, clinical correlation, and no standardized scoring. Next came the Acosta classification in 1973, which was based upon the site of the disease, extent of adhesion, and degree of tubal involvement. Then again, the limitations are poor correlation with the pain and the infertility. Then came the American Fertility Society classification in 1979. It is based on the size, depth of the implants, additions, and involvement of the tubes, ovaries, and the cul-de-sac. It has 4 stages. Stage 1 where there is minimal involvement, stage 2 where there can be some more, and stage 3 where you can see the peri-ovarian, peritubal addition, and stage 4 it is dense where the pouch of Douglas is totally obliterated. Then came the revised AFS system in 1985. Again the same staging, stage 1, 2, 3, and 4, but instead of just they had marked in the numerical order whether it is less than 1 centimeter or 1 to 3 or greater than 3 centimeter, and whether it is over the peritoneum, whether it is superficial or deep, or over the ovary, or the cul-de-sac obliteration, and again the additions, whether they are flimsy or dense. So this is available in the net, and then you can always, during the surgical procedure, we can mark it and we can get a scoring system. So if it is less than 1 to 5 points, it is stage 1, 6 to 15, it is stage 2, 16 to 40, it is moderate, and greater than 40, it is very severe. So the poor, here again, the limitation is poor symptom correlation, inadequate for deep endometriosis, and it is based on surgical findings and cannot be used for preoperative assessment. Then came the revised ASRM classification. Minor revisions, including regarding the clarity and reproducibility, are made, and use of point-based system widely adapted for clinical and research use. So here again, you can get this picture from the net, and then you can mark it, and then we can come to a scoring system is available. So again, it depends upon the mild one, it is only 4, and in the there is minimal one, then mild one, moderate, and again severe and very severe lesion. Here again, the lesion limitation is it fails to predict the pain severity, infertility, or prognosis. Then came the enzyme classification. Enzyme classification integrates the superficial, ovarian, and deep lesions to create a more comprehensive mapping system, and it is compartmentalized. It is peritoneum, it is ovaries, and the tubo-ovarian condition. Then again, you can have the rectovaginal space, then uterosacral ligaments, and the C is the rectum. And apart from this, this has facilities for long other locations of endometriosis, such as the bladder, ureter, intestines, or the diaphragm, etc. So you have a separate column for that. The lesion site is graded from 1 to 3 with 0 indicating no involvement. Unlike the traditional RSRM or ASRM or NCN is designed to be used along with ultrasound and MRI for preoperative mapping. So that is an advantage. I think I can skip this endometriosis fertility index that has been assessed by Adamson et al. In 2020 because Dr. Pratik had already described it. And this is an easy one. But the note that it should be marked only at the end of the conclusion of the surgery so that the scoring can be from 0 to 10. And this will give you an idea what plan you should go regarding the fertility. Whether the patient can conceive spontaneously or whether she needs ART or whether she can be given few trial of ovulation induction or with IUI. So I wish every surgeon who does endometriotic surgery, you should make a mark about the endometriosis fertility index in their operation notes. So that will be very much helpful for both the surgeons as both the consultants who are going to treat the fertility as well as the patient. So then AAGL introduced a newer staging system in 2021. Here again, it scores the various lesion types, classifying into core 4 complexity levels. Stage 1 is 8, less than 8 points where there is minimal disease. 8 to 15 is mild. 15 to 21 is moderate. Greater than 21, it is a severe disease. So again, this chart is given and you can easily mark out where are the lesions. Then it is again used for preoperative evaluation using ultrasound. Good concordance between staging and surgical outcome are observed. It helps in surgical planning comparable to the ASRM staging, correlating with fertility and the pain. So that is the latest one. So to summarize, this gives you an idea which year, which classification, what will be the focus and what are the limitations. So now what is the update in diagnosis? It is Professor Charles Chaperon who always says that there is no place for diagnostic laparoscopy when endometriosis is clinically suspected. This was in the year 2019 and he still, I think now all the learned societies like ASHRAE, ASRM, Indian guidelines, everybody is for non-invasive or diagnosis of endometriosis based on the clinical features and the symptom. Again, non-surgical diagnosis is the norm today. You can diagnose it clinically or by radiological evidence. The radiological evidence means a simple ultrasound or an MRI. And of course, biomarkers are going to come in a big way. See, the ASHRAE says that biomarkers should be used in non-surgical diagnosis only in research setting. But I think soon there will be options where biomarkers can be used for screening all the women who suffers from symptoms of endometriosis. Already Philips Deschamps has started using the salivary miRNA as a biomarker. Again, the symptoms, I am very fond of that 7 Ds plus following that fatigability, and it can be mixed with other symptoms can be like IBS and chronic fatigability, headache and depression will be there. So the mode of being a neuroinflammatory disorder, it is the therapy is varying. So surgery is no more the first line. Medical management is the first line. Then again, you can also combine with the diet that is feasible in these patients to reduce the inflammatory symptom. digital apps are now available so that based on the symptoms, the patient themselves can get diagnosed whether they have endo or not. And of course, physiotherapy, mindfulness, and cognitive behavioral therapy are all used. Then imaging, I have already mentioned, ultrasound and MRI play a major role. And the ultrasound is the basic one. For endometrioma, you can get enough of evidences to say this patient has got a endometrioma. And again, MRI is needed in patients who have got deep infiltrative lesions. When you plan for surgical management, I think it is the ideal one. So now coming to the advances, advanced imaging and artificial intelligence, that is coming in a big way, that can refine ultrasonogram and MRI, AI-assisted image interpretation, and multimodal imaging approaches can give you a clear-cut idea regarding the involvement, and they can anatomically place what are all the regions, what are all the sites where endometriosis is affected. And this is the IDEA group, that is International Deep Endometriosis Analysis Group from Monash University, Australia. They have taken a simple transvaginal or a translectal ultrasonogram to find out what are the areas, specific areas, deep infiltrative endometriosis in the bowel has been affected. And they have so many signs like CoQMAN sign, moose antler sign, India's headdress sign, and pulling sleeves line, which can help us in diagnosis. Though MRI can also be. So here the MRI can pick up, and this is a laparoscopic view in superficial endometriosis. In endometrioma, this MRI can be compared with that of the laparoscopy. In deep endometriosis, here you can see the lesion in the laparoscopy the same way it is seen. And again, in the tubal endometriosis can also be done. See, general teaching is MRI will not pick up anything that is less than 1 centimeter or at least 7 to 8 millimeter. Now, the AI-assisted image interpretation and machine learning are being applied to MRI and ultrasound data to improve the detection of these subtle diseases. One research project developed in AI framework to recognize the neural involvement in endometriosis is also available nowadays. Other researchers use human AI collaborative systems to better interpret the pelvic MRI images for endometriosis signs. So the advances still, there is multimodal imaging approaches where they have combined different imaging. Example, ultrasound and MRI can be combined, and one information can be translated to the other so that it can give a better result. Still, even then, we don't have a best imaging technique that can rule out superficial lesion. For that, other advancing images like the 99M technetium macra-C cladi SPET detects the superficial lesions for better trials in patient selection. Then other symptoms, that is femtech tools like AI symptom trackers, wearable by the patient, can pick up when you monitor the pain, and added to that, the biomarker test can help to reduce the delay in the diagnosis. These integrates trials to boost specificity and outcome. So always biomarker, clinical biomarker plus the imaging evidence can reduce the time for diagnosis. So there are certain biomarkers which can reduce the diagnostic time, follow-up time, and biomarkers could be considered clinically useful, monitoring the progress of the lesion, and to replace invasive by diagnostic method. And the criteria to have it is to say the biomarker is, it should have a higher sensitivity of 94% with a specificity of 79%. This is a spider diagram to show what are all the possible non-invasive diagnostic markers. But here you see the proteomics, metabolomics, and the microRNAs are gaining much valuability in this in this situation as a biomarker. So it can be combined with vaginal examination, serum interleukin, and PGP staining. This is what the endometrial PGP staining can pick up the sensory neural fibers, which are a manifold time increase, and this can be used as a quasi-invasive procedure in diagnosis. And from the history and other all the CA125 and CA1919, and there are so many biomarkers which can be used. Then again came the role of nanotechnology in diagnosis. You can have biosensors that is coming up in a big way in diagnosis, fluorescence imaging, photothermal therapy, and then MRI immunotherapy, and then gene therapy. They are all going to be in the future in management. Now, emerging and integrative research approaches, combined test strategies, that is combining biomarker imaging with clinical models. So, advanced statistical methods like lasso regression and AI are used to refine and combine clinical biomarker and imaging data to create a predictive model which will improve the diagnostic performance. And then now again, we have novel sample sources like innovative studies that are exploring the menstrual blood and extracellular vesicles from the menstrual blood as a newer diagnostic sources, potentially enabling the simple home testing. Again, BCL2 is a gene that is dysregulated in endometriosis that has also been under research by certain group of people. Then microbiome. Microbiome, I said already, the microbiome, it is abnormal in endometriosis. By DNA sequencing using 16S RNA marker gene, you can pick up all the bacterial composition, and generally the lactobacillus is reduced and the other groups of Enterococcus and Pseudomonas are elevated. So the bottom line is, while non-invasive diagnosis remains under active research, no single test has replaced the surgical diagnosis. However, the progress is rapid, and multivariate approaches combining biomarkers, imaging, and AI symptoms can show greatest promise of delivering an accurate non-invasive diagnosis in near future. Then coming to the medical management for pain, surgical management, and ART or surgery for women with infertility. So the limitation of medical management so far is it is symptom relief only when the patient is on treatment and it has got definite side effects, and recurrence is common once when you discontinue the tablet. So now the treatment is whether you can treat it without or with histology. Every society is for treating the patient only based on symptoms, not based on histology. So what is the perfect drug for endometriosis? It should destroy the lesion, it should reduce the symptoms, used for long-term treatment, limited side effects, and it should have a low cost. To get a drug which has got all this criteria is difficult, and there are so many limitations. And then the drug therapies commonly used are COCs, NSAID, GnRH agonist, and progesterone. But now we have an excellent group of this antagonist that is helpful in reducing the symptom with variable doses, and we have this progesterone antagonist, and then anti-angiogenic drugs are also coming up in a big way, because these anti-angiogenic drugs will not inhibit conception. Then again, Dr. Pratik has described so much about the dydrogesterone, which I find it is very, very useful in women who want to conceive, especially following soon after surgery. Then again, estrogen receptor beta ligand is also another drug which can help to promote fertility. Then we have, of course, aromatase inhibitors as the second line. Statins are under trials. SERMs and PERMs can be tried. So the key feature to new approach to endometriosis management is long-term, lifelong medical management. Newer hormonal drugs, especially antagonists. Non-hormonal treatments are also coming in a way, and multimodal treatment for the comorbid pain symptoms, and it should always be a multidisciplinary approach. So this is agonist which we have been using, and now everybody has started using this antagonist, either elagolics or elagolics, and of course aromatase inhibitors as the second line of drug. You can use it, but not for a period more than 6 months, as it can reduce the BMD. And then hot flashes as the side effects. And these are all some of the newer drugs like tumor necrosis alpha inhibitors, pentoxifylline, tumor alpha converting enzymes, serotogenic modulators. Gabapentin are one excellent drug which can counteract the sensory pathway, that is nociceptive pathway can be inhibited by this. And again, this Anginex, rapamycin, these are the drugs which can reduce the VEGF, and doxycycline can be used as to counteract the abnormal microbiome. And Palmiger is one newer drug that has been tried extensively, which contains ethanolamines and some of the substances like didesin and gencitin, which can be magnesium, which can help to cope up with the pain. So then coming to the endometrial stem cells or the bone marrow derived stem cells. These stem cell theory suggests that dysregulated stem cells from the endometrium or other sources drive endometriosis development. So now the therapeutic potential is These same stem cells can promote tissue repair. It has got an anti-inflammatory effect. It can have a targeting effect upon the treatment is target based, and then challenges in the future directions are always we cannot use it for a long term. Probably the chances of getting tumor risk and storage of this stem cells. So these are all some of the problems, but the lot of scientists are working on this. And then again, immunotherapy being an immune disorder dysfunction is the basic cause. Immunotherapy can be used. And of course, yes, I'm just going to conclude. Alternate therapies are there. And in the surgical thing, now we have moved on for the excision of the lesion over cauterization, cystectomy over preservation, and then multidisciplinary team is needed. And again, you can have the robotic surgery versus conventional in selected cases. And then finally, in ART, we have Pratik had already mentioned how we have changed our views and protocols so that we get the good results. And then, of course, this has to be followed up. And by Ward study, they say that in IVF, the results are much better. And phase 3 pregnant trial also says that GnRH agonist can be used. So ultimately, the clinical takeaway is multimodal approach, best outcome often to involve a combination of surgery, individualized and personalized care, and more than that, if early referral is always needed, and future is going to be AI based, and we have to concentrate on future research. It roots at utero, starts at 20, progresses at 30, problematic at 40, supposed to end at 50, malignancy risk at 60, needs follow-up forever. So once endo-patient means lifelong, she is going to be an endo-patient. So thank you for the opportunity given to me. Thank you so much.
Mesmerizing talk. You are the master, Ramani.
Thank you.
Master
thank you.
of endometriosis. I think that was a mesmerizing talk. Everything you have included and so beautifully presented. So excellent. I think just chairpersons, if you have any comments, please.
As rightly pointed out,
that madam has really, given a super talk from A to Z of endometriosis. Really,
Thank
she
you.
has that passion and zeal for teaching. I would say that really superb, madam, Ramani madam. Yeah, please, Sonia madam, you can go ahead.
Yeah, I think after the talk, it is our duty as being in this fraternity that we have that EFI chart. And I think every post-operative record should be inclusive of this, so that if there is a referral also, because a lot of times what is happening is an endometric diagnostic histolaparoscopy is done, and that's been repeated, that is what is happening. She shifts from city to city, center to center. So if this EFI is already registered in her discharge summary or card, and that it's make more senseful. And I think 50 million is quite a big number. And we have been in the front to treat these women. And I think this awareness month is very productive, and madam has always been, I think every second day in every forum, madam is speaking about this. We'll definitely take it forward, madam. Thank you very much.
Thank you. And keep a recording of the surgical procedures. That also helps.
Nowadays, we are giving a pen drive also.
Yes.
And that's...
Thank you, Dr.
Thank you.
Sonia. Thank you, Dr. Jagruti. Can we invite next speaker?
Yes.
Yeah, any of you?
Yeah, at the outset, I would really like to thank Brijwala madam, who has given me the privilege to be a chairperson in this annual CME. Thank you, ma'am. With that, we invite our next speaker, Dr. Ajay Agarwal. He is the Secretary of IAG Punjab chapter. He has received an Endoscopic Surgeon of the Year award twice by Economic Times. He is a trainer and teaching faculty in gynec laparoscopy and has a key interest in laparoscopic adenomyomectomy with flap overlap techniques, laparoscopic cervical surgery, cerclage, asthmocele, scar ectopic, and fertility enhancing surgeries. Welcome, sir.
Welcome, Dr. Ajay.
Everyone. Good evening, everyone. So thank you so much for this opportunity to me. And I wish all the best to Archana ma'am for upcoming election. And now I would like to...
And I witnessed, Dr. Ajay, your surgery 10 years back in Indore Life Care Hospital.
Thank you so
I think
much.
it was 2016 only.
Yes, ma'am. So, ma'am, my screen is visible to all of you or not?
As
It's
of
not
now, no.
complete. It's
No, it's not. No, it's not visible.
It is not visible. Just a minute. Stop sharing. Now share screen. Why my presentation is I'm not able to share over here. Entire screen share.
Yeah, now we can see.
Now you can see my screen.
Yes.
And now you can see my presentation.
Right.
Now it is visible.
yes.
Okay, fine. So without wasting much of time about the endometriosis, because see, most of the elite speakers, they have already talked about the endometriosis, medical management, about the fertility part. I will focus mainly on the surgical part. Okay, so by introduction, there are three types of endometriosis: peritoneal endometriosis, ovarian endometriosis, and deep endometriosis. Deep endometriosis, which is also known as invasion of the endometriotic implant 5 millimeter below the level of the peritoneum. Now, depth of the invasion has to be more than 5 millimeter. Infiltration can be, see, in the pelvis, the infiltration of the endometriosis can be anterior to the uterus, that is the bladder, lateral to the uterus, that is the ureter and the parametrium, posterior to the uterus, that is the rectovaginal space and bowel, and below the level of the uterus, that is the vagina, above the level of the cervix, that is the adenomyosis, right? So all these patients, whenever we are talking about the deep endometriosis, they will present mainly with severe pain, infertility. These are two main symptoms. Then, because of inferred and severe pain, they usually have psychosexual dysfunction, deep dyspareunia, compromised quality of life, and loss of effective productivity. So our four questions have to be leading. There has to be leading question, five leading question. Whenever we say that patient is having dysmenorrhea, we have to ask about deep dyspareunia, not at the insertion of dyspareunia. It has to be deep dyspareunia, especially when you are doing TVS and the probe is going in and patient winces in pain. That is deep dyspareunia. So you have to ask the leading question. Then comes your dysuria, dysphagia, and chronic pelvic pain. So these five questions have to be leading question. It has to be mentioned for all the patient of endometriosis. Now, what is funny part about the endometriosis, whenever we are seeing a big size endometriosis cyst, let's say 8 centimeter, 10 centimeter, these patients, they usually are less of symptomatic considering the pain. Why? Because these ovaries are free, they are not stuck deep in the pelvis, the adhesions are not that bad. That's why those patients, they usually have less of component of infiltration and pain. But those patients with smaller size of the endometriotic cyst, they have severe pain. Why? Because of grade 4 endometriosis, dense adhesions, the ovaries are stuck in the pelvis, and whenever there is menses and it starts to grow bigger inside, it causes extreme, very bad pain. So treatment already been discussed, medical and surgical. This guideline has already been discussed. So I will directly jump on the laparoscopic part of the deep endometriosis. So steps we have to memorize. Steps are, you can say mnemonic is SOUP, SOUP, or you can say so sure. SOUP is easier to remember. S is for sigmoid mobilization. O is for ovary. So ovary means you have to make the ovary free, means ovariolysis. Then you have to do the ovarian cystectomy, and then you have to suspend the ovary. That is ovariopexy. Fine. So O is for ovary. Then comes U for ureterolysis. So in deep endometriosis, you have to protect the bladder, bowel, and ureter. So ureter is something which is usually pulled up towards the deep endometriosis in most of the cases. So that's why it is very important to do the ureterolysis whenever you want to do peytonectomy. So SOU, U is for ureter, and then P stands for pararectal space dissection and the peytonectomy wherever infiltration is there. So excision of the deep endometriosis has to be done. Now, in cases of ovarian endometriotic cystectomy, especially when we are talking about infertility, it is very important that we preserve the functional ovarian tissue, right? So how can we achieve that? First thing is your plane of the cleavage between the cyst wall and the functional ovarian tissue has to be excellent. It has, the cyst wall has to be thinnest possible, which is actually required. But the problem is it will lead to lots of bleeding, and then we usually end up using more of cautery, right? So to mitigate that, what you can do is you use vasopressin 20 unit in 300 cc of saline and inject it either in the uterus directly, because it will work on the nexa as well, or you can inject in the ovarian tissue. And then you start doing cystectomy. Believe me, your planes will be much better, and overall your bleeding will be less. So the damage to the ovary is actually very, very less, right? So it will lead to minimal use of cautery, and the correct plane, as I mentioned, because of hydrodissection, the correct plane will be better. So, but in cases of where the planes are very bad because of fibrotic area, there you should use Caesar, ultrasonic energy, or Scherer, whatever, rather than doing blunt dissection,
Dr.
because
Ajay, your
Anji ma'am,
slide is not visible now.
my slide is not visible now.
No, sir.
It was there and then it went off. Yeah.
Yeah, it just went off 5 minutes back, sir.
Yeah, initially it was there.
Just a minute. I'm sharing my screen again. Okay, now you can see my screen.
Yes, sir.
And now you can see my presentation. Done. You can see my presentation?
Yeah.
Yeah.
Yes.
Then last part is the confined drainage in the trocar directly to avoid soiling of the plane. So what do I mean by this? See this video, all of you can see this video. So this video is very important whenever we are talking about ovarian cystectomy, especially for infertility, where we want to preserve the uterus. See, this is confined drainage of the cyst. Trocar directly goes in the cyst wall, and then we do suction. Okay, trocar comes out, suction cannula goes in, and we do the suction. Then this is the ureterolysis. You can see here. Now this is the complete drainage of the cyst. The uterus has been made free. The posterior is free. Now, hello. Now, we are focusing mainly only and only on the cystectomy. See here, there are two type of technique. One is three trocar technique. Second is two trocar technique. In last cyst wall, you use three trocar. That means three instrument. One of the assistant is holding the cyst wall or the ovarian tissue to guide you so that you don't lose the plane. And the main surgeon is finding the correct plane with the help of the two instrument. As you can see in this video, the planes are excellent. They are beautiful. In this case, I have not used much of vasopressin. That's why it is bleeding. Okay, you can see the plane. So you have to apply the divergent forces. Now, in big cyst wall, now in this particular case, what I've done, it is called inversion technique. Inversion technique means you cut open the cyst and invert it so that the entire cyst part comes right in front of you so that you don't lose the correct plane. Okay, this is called inversion technique. See here, the entire inside part of the ovary is there in front of you, and then you keep on making the correct plane. Always hold the cyst wall or the ovarian tissue up in the air so that the gravity works for you and the cyst wall or the remaining part of the ovary goes down. This is point coagulation of the ovary, only point coagulation of all those bleeders, big bleeders. Small bleeders, you don't have to do anything. You just apply pressure, or you can take some sutures for that. Otherwise, please don't burn the ovary. And once your surgery is complete, this is, you can see here, the inversion has been taken care of, the ovary has been closed. So that's why in most of the cases, the suturing is also not required. Why? Because the row surface is not much. Okay, that is the beauty of inversion technique. I think this surgery is clear to all of you. Now, what you can see is my assistant is pressing against the ovary. What we usually do in most of the cases where there is bleeding, we apply the pressure. So the ovary is, applied pressure with the help of the assistant. Now coming to the next part, adenomyosis. Adenomyosis. Good morning, everyone. This is Dr. Adenomyosis, I think I will skip because we are mainly focusing on the endometriosis, and that is a big video. So I would like to show you few of the videos of deep endometriosis because of the paucity of time. So this case is having a complaint of menorrhagia, dysmenorrhea, and dyspareunia. Now, on your PS examination, whenever patient says dyspareunia, please do a PS examination or PV examination posteriorly. You can see this is the cervix, and posteriorly you can see the nodule. This is the endometriotic nodule. Cervix ho gaya. You can see here in this vaginoscopy, these are the endometriotic nodule in the posterior fornix. It is infiltrating in the vagina, right? So in this is the laparoscopic view of the same patient. You can see the pelvis is clean. You go inside and you will realize, okay, fine, there is nothing to do. But this patient is symptomatic. So what you have to do? You have to do complete uterolysis. From laparoscopic view, you have to excise the complete nodule. Then only she will be symptomatically free.
Can you
right?
Ajay, again, your video
Is
is
very, very, very important. Okay. Then I'm
Ajay,
showing you
again, your
another.
video is not visible.
Sorry, sir.
Can you
Your
just check
video,
this?
yeah,
Your
again,
slides video not up.
My slides are not visible.
No.
Again, it went क्या?
Again, yeah.
मुझे लगता है ये लोग ना they won't let me show my video. Wait. I'll show you like just few of the videos. I think now it is visible, please.
Yes.
Yes. Fine. So I'll just focus on mainly on the rectovaginal part. I think there is something technical problem with the either with my laptop or with the Zoom. I don't know. Now see, this is the ovarian suspension I was talking about. This is visible to all of you.
Yeah.
Yeah. So the ovary has been suspended laterally so that all I can focus is in the POD. Now this entire dissection is done. You can see the uterus is lifted up. Okay. I thought my surgery is complete here. Okay. I thought. Then I did my PV examination. When I did my PV, you can see my finger. I could palpate the nodule. I decided to dissect more in this plane. And you can see here what I'm doing with the help of the harmonic. I started dissecting. You can see this brownish color. Now you can see this brownish color. Is it visible?
Yeah.
So that is the deep rectovaginal nodule, which is not infiltrating in the vagina. Earlier, I showed one of the video which was infiltrating in the vagina. In this case, I'm showing you the rectovaginal nodule, which is not infiltrating in the vagina, but it is in the rectovaginal fascia. So this patient was also having deep dyspareunia all the time. If you don't dissect it off, then patient will always stay symptomatic. Okay, the surgery will be incomplete. She will come back again after 1 year or 2 year for surgery, or she will say, surgery is not going to work for at all. The quality of life will be compromised. Now you can see here, this entire nodule has been excised. Then I'm just showing for demonstration purpose, for the recording purpose, with the help of the scissor. When I cut, you can see the brownish infiltration in the fat. Yes.
Yes.
So that is what we achieve in complete surgery. So what is the most important part in endometriosis? To make correct diagnosis and to do complete correct surgery. Then I'm doing PV examination, and now I'm sure yes, the rectovaginal fascia is totally clear. Okay.
Good morning, everyone. So
now
today I'm going to present a case of
this is again one more surgery of rectovaginal endometriosis. I will skip from here. Third case is about dysuria. Dysuria, this is again, you can see here in the MRI, this is bladder endometriosis apart from the ovarian endometriosis. Bladder endometriosis is not uncommon. The incidence is almost 3% in cases of deep endometriosis. I personally have operated 5 cases of bladder endometriosis. Okay. Now see here, the first picture is of big endometriotic nodule in the bladder. This is the cystoscopic view. And in the bladder, this is the nodule of the endometriosis in the bladder. See here, these are the images where I have opened up, I have stented the ureter, I have opened up the bladder, and then I have sutured it. This is another case of bladder endometriosis, not that one, where I'm just showing this. This is another nodule of the bladder. Ureter has been identified. There is good distance from the nodule, so that's why stenting is not required. Stenting is required only if the distance between the ureter and the nodule is less. Now, see this, the entire pelvis is clean. There is hardly any endometriosis. The only problem she had was dysuria. Even family was complete. But just in case, see, if you want to do medical management, you have to counsel the patient. There is a possibility that the size of the nodule can increase, but it will never go off. So eventually, all these patients need surgery. So bladder has been dissected off. You can see here laterally. You can see here this is the lateral to the left lateral part of the bladder. This is the right paravesical area. Then this is the nodule. Nodule is being dissected off from the previous cesarean scar. Usually isolated bladder nodule, they may be associated with previous cesarean scar at the time of cesarean. Then again, the complete dissection is done. Ureter is identified. And then we caught the nodule, and with the help of the bipolar sharer or ultrasonic energy, you have to cut it open, do cystotomy, and take out completely. My video is clear to all of you, please? This video is
Yes.
visible?
Yes. Yeah.
Now
Yes.
see this. Cystotomy is done. This is cystotomy done, right?
Now it has gone.
Now
Once
it
cystotomy
is not visible.
Huh?
Suddenly
This
it
is bladder
disappeared.
nodule.
Yeah,
Video
it
gone.
Disappeared.
Now it
yeah,
has disappeared.
eyes have again gone off.
I think this is the last video I will show because there must be some technical problem. So that I don't waste much of time, I will share this last video so that we can see here. Now it is visible.
Yeah.
So bladder endometriosis, we can see here the bladder has been opened up, cystotomy done. This is the bladder nodule over here, a big nodule. We can see the ureteric orifice. This is right ureteric orifice, nicely visible. Similarly, left ureteric orifice, it is far away from the bladder nodule. So we did not stent it. We removed the bladder nodule completely, and then we sutured the cystotomy. The Foley's was kept for 2 weeks. Then it was removed. Patient passed urine after it, and it was totally painless for her after years. See here, it is being repaired in 2 layers, and then patency is checked. This is by cystotomy, and this is by retrograde filling of the bladder. So that is it. So thank you so much. I have lots of other videos, ureteric endometriosis, bowel endometriosis, but paucity of time, so I would like to skip all of these. Thank you so much for the opportunity given to me.
Thank you, Dr. Ajay. It was really nice to hear you. And please do come for the conference, and we'll like to listen you once again.
Thank you so much, ma'am. Thank you.
Excellent surgical skills, sir. Sir, you were mentioning about vasopressin dilution. Could you just repeat that? Because
Ma'am, earlier I used to dilute 20 unit of vasopressin in 150 or 200 cc of saline. But then we realized the overall complication rate is slightly higher because the dilution was not much. Then we started doing it like at least since last 8 years, 8 or 9 years, 20 unit in 300 cc of saline. So then after our complication rate dropped because of vasopressin that we used to face. And second thing, the hydrodissection was also helping us a lot. So now currently we are using 20 unit in 300 cc of saline.
Okay, because we've been
We
very
don't
promptly
inject
using
completely.
myomectomies.
We don't inject like completely 300 cc of saline. We inject when we achieve we stop when we achieve the blanching.
Blanching.
Yeah.
Thank you so much.
Thank you, Dr. Ajay. Thank you so much for sharing so beautiful videos.
Thank you so much, ma'am.
Thank you so much, sir. It was an amazing talk, and we really learned a lot from your surgeries. So moving on to the panel discussion now, I invite our moderators, Dr. Animesh and Dr. Harshal, to invite our moderator for the next session and the panel also.
Thank you, ma'am. So moving forward toward the next session of the evening, now we have a very interesting panel discussion about the IVF cases in endometriosis. And for the moderation, may I please welcome Dr. Chaitanya, sir. Sir is the founder, chairman, and MD at Omega Hospital Private Limited, Nagpur. Sir is also the General Secretary of Maharashtra ISAR in year 23-25. Sir is President of Om Charitable Foundation. Sir is a past President of Ops and Gynae Society, Nagpur, and Vice President of Tevankar Organization of Medical Students.
I think
That
that's
is
okay.
also
We
member.
will.
Yeah.
You
So
just
the
skip
list
this.
goes on. Sir is a
training.
recipient of many awards and published many papers over the years. Sir, we are honored to have you here as a moderator, sir.
Thank you so much.
And
I think
with
without
your
wasting time,
thank you, sir.
shall I start sharing the screen?
Sure, sir. Sir, with your due permission, shall I welcome our panelists first?
Yeah, sure. Yeah.
So we have a galaxy of esteemed panelists present over here, sir. Let me please welcome our first panelist, Dr. Tabassu, ma'am. She is a Vice President, Raipur Menopause Society and a Joint Secretary of Society of Vaginal Surgeons of India. Welcome, we welcome you, ma'am. Our second panelist is Dr. Sheetal Jindal, ma'am. Ma'am is a Senior fertility consultant at Jindal IVF Chandigarh and a co-convener of SIG Applied Genetics in IFS. We welcome you, ma'am.
Thank you.
Our third panelist is Dr. Akriti Gupta, ma'am. Ma'am is a treasurer at Dehradun at Foxy and past secretary of Uttarakhand, ISAR. We welcome you, ma'am.
Thank you so much. Very good evening.
Thank you, ma'am. Another panelist is Dr. Yukti Bharadwaj, ma'am. She is a consultant at Benison IVF Noida, and she has recently won the National ISAR Q, which was held at Ahmedabad 2026. So congratulations and we welcome you.
Thank you so much. Thank you for the kind invitation. Thank you.
Our next panelist is all the way from Guwahati, Dr. Kanchan, ma'am. Ma'am is a General Secretary of Northeast ISAR and a Vice President of Guwahati Ops and Gynae Society. We welcome you, ma'am.
Thank you. Thank you so much. Thank you for inviting me here.
Our next panelist is Dr. Shivani Joshi, who is a Medical Director and Owner at Total Fertility Solution of IVF. She's a gynecologist, she's a lawyer, and she's a certified embryologist as well. So we welcome you, Dr. Shivani.
Thank you. Thank you so much for having me.
Our last panelist is Dr. Himani Patel, ma'am. She's a Central Head of NOVA Wings at Baroda. We welcome you, ma'am. I think she has not joined yet. Maybe she will join.
Inviting. I'm here only.
Oh, yeah, she's here. Okay. So over to you, sir. Chaitanya, sir. We can start moderating the session.
Thank you so much. I'll just try to share my screen.
We are always eager to listen your panels, Dr. Chaitanya.
Thank you so much. There is some problem with screen sharing. Yes. I don't know, some problem with the.
So you have started sharing your screen?
I'm trying to, but I'm not able to start sharing. Some problem is cropping up. I don't know. Google Chrome app bundle would like to record this complex screen and audio.
Thanks a lot. Thank you. Thank you so much that I was not the only one.
Yeah. I thought that I was pretty sure that I won't have any problem, but then it looks difficult. I don't know.
Hello, Chaitanya sir. This is
Yes.
Bhakti this side.
Yeah, Bhakti.
Someone else can if you're comfortable, you can share with us your slides, so we can.
Yeah.
I don't know. Deny.
So you can try share your screen, full screen window, full screen. That's what I tried. Share full screen.
Yeah, that is what I am trying to do, but it is coming that Google Chrome app bundle would like to record this computer screen and audio. Grant access to this application in privacy and security settings, located in system settings. I am denying it, but then it is
accepted, no?
Now I have denied it, but then I'll accept it. But after accepting, open system settings. Okay. Modify settings. I don't know, there's some problem.
Chaitanya, why don't you email? Can you email your presentation
You can share
to
your
someone
email
and they
on
can
WhatsApp.
present?
Yeah. This is
You
can email
you
to
can
Dr.
share your
Anish.
presentation to someone of us, then we can share our screen.
Can you mail to Bhakti, Dr. Chaitanya, in the group all either?
Sir, you can
I
even share
just dropped
the
my
group.
mail ID to chat box. If you want, sir, you can just send it to me.
Anyways, Archana ma'am, the CME has gone off very well and very nicely organized, and they were very nice lectures. And also, best wishes from our side for your upcoming elections too.
Thank you, Dr. Sheetal. Thank you so much.
And thank you so much for this opportunity also. For inviting us for this wonderful webinar. Let's hope we are able to carry on with this.
I think we will be. Dr.
Yeah.
Chaitanya may share his this presentation to Bhakti. Bhakti's mail is there, Dr. Chaitanya.
Password, I'll try. ID?
ID, sir, actually, we don't have a ID actually. Meeting ID.
I think they shared the link directly. They shared the link only.
Good evening, everyone.
Hi, Dr. Rakhi. Good evening.
Hello,
That
hello,
time
madam.
your video was
Sorry.
not visible.
Yeah, madam. Madam, thank you so much for giving me chance over here, and sorry for the
No, we are blessed to
inconvenience
have
created.
all of you. We are blessed to have all of you.
Madam, like the CMA is going very nicely, very nice topics. Thank you so much, madam. And I would like to convey my all the best to Archana madam for her foxy presidential elections, and my best wishes to you also for your future endeavors. Thank you.
Thank you.
So much.
Thank you.
Thank you, Dr.
Thank
Rakhi,
you.
for joining.
Thank you. Madam, my best wishes from Jabalpur Obstetric and Gynec Society to
Thank
you.
you. Thank you. I have seen the amount of work you guys do. Tremendous. Recently, at my visit, I witnessed it.
Thank you. Thank you so much, madam. Thank you so much.
Rakhi is always working so hard. Na, last year she planted 1,000 plants in Jabalpur and they are growing well. She's taking care of that. So for the environment, she's working hard.
Thank you so much, madam, for involving me in environment committee, and it's my pleasure to work with you, madam.
Dr. Chaitanya, can you have without presentation then?
Yeah, you can ask the.
Yeah.
Just.
So you can start asking the questions. The panelists are all over here, ready, waiting for your questions.
And without the PPT, I think.
Sir can put in on the group if it is possible. What on the WhatsApp group if it is easier.
I think Dr. Chaitanya has logged out. He's trying to log it again.
Not visible now.
He has logged out. He's trying to log in again.
Okay.
Hello, Archana ma'am. Hello, Brijbala ma'am. Thanks for inviting me for this esteemed panel today.
Yeah, Tamal. So it's good to
What
see
happened?
you on
Braj, nahi aaya kya Chaitanya ka?
Ma'am, he logged out. I think that some issue in sharing the PPT.
So, is he giving it to somebody or should we do a panel discussion?
Yes, madam, we are asked Dr. Chaitanya to share it to Bhakti.
No, he can open his laptop and just ask the question.
Yes, Archana ma'am, he is trying so hard to send us that PPT.
Yeah,
Please.
let him send, and meanwhile he has cases in his head, so need not do the PPT. He can just take it without PPT.
Yes,
That's what I'm
madam,
saying.
Yes.
Yeah, because all the panelists are eagerly looking for the panel, and so are we. So we can tell Chaitanya that PPT meanwhile
I'm
it is
calling,
coming.
ma'am. I'm calling.
And then we can do without PPT also. So how
Good
is
evening.
everyone?
Good evening, ma'am. Archana, ma'am. Good evening.
How are you, Kanchan?
I'm fine, ma'am. Ma'am, thank you for inviting and all the best to you, ma'am.
Thank you. How is
We
Sheetal?
from Northeast, we all are with you, ma'am. We'll try level best.
Thank you
there.
so much.
Kanchan,
You're always
Can
been
you
there with
start
me.
without PPT?
Yes, ma'am.
And how are you,
Now I have
Sheetal?
joined, but then I think
Everything fine, ma'am.
I
We
have
can do Chaitanya. You can see your laptop.
yeah
You
without
can present
PPT
the
also.
case and just ask the questions. So that
But I
will
have
do meanwhile.
WhatsApp केले. काय नाव आहे तिचं? The yeah, I have already sent the PPT to काय नाव आहे तिचं?
Bhakti, sir. Sir, you can start
and
asking the
it
questions.
is
Meanwhile, she will share the screen.
yeah. I'll start. Yeah.
Okay, sir.
Yeah.
And also share
Yeah,
on the
I'll do that.
WhatsApp group if possible.
Yeah, that's why
I'm
it is
really sorry
always
for
good,
that.
no, Chaitanya,
Yeah,
to
I have.
share it in the advance to panelists, so one of them
I'm so
can
sorry for
project.
I haven't received it, your sir, PPT. Could you please check your connection or something? Like,
Sir, you are on the WhatsApp group. If you can share on the WhatsApp group,
Yeah.
every panelist and everyone will be able to see it.
ते वेळ लागतो त्याला ना. I'll नाही होत आहे ना तेच तर होत आहे ना.
So you can share on the WhatsApp group your entire PPT, and that will be a good reference point.
हे इथे शेअर करू का? हे कसं शेअर करू? एक मिनिट. शेअर कुठे गेलं ते?
शेअर स्क्रीन करून करता येईल ना? शेअर स्क्रीन करायचं.
Can you see this now?
Yes, we can see a screen.
Yes.
Presentation?
Not yet, sir. Not the presentation.
Not yet.
Sir, your entire screen is visible, so now you can maximize your presentation and start.
कसं करायचं?
Sir, you're in the airplane mode.
You're in the airplane mode.
Sir, you have to off the airplane mode, then only. Yeah.
काय करायचं? कुठे आता शेअर होत आहे का?
विचारलं तुम्हाला दिसतंय. शेअर होत नाही. You are sharing screen.
Yes. Can you see the screen now?
Yeah, we can see the screen which is showing Omega Hospital.
Yeah.
Yes.
So yeah, I think now it is there.
Yes, it is there
Right?
now. Esteemed panelist is written there.
Yes. So esteemed panelists are already there on the board. So I'll without wasting time, I'll start the panel. And so we have already introduced all the panelists. But then something which is very interesting as far as endometriosis is concerned is that it is an enigmatic disorder. And as our circle of knowledge expands, so does the circumference of darkness surrounding it. And we know that it's a chronic inflammatory disease. And we know that the number of patients is increasing day by day, because I remember when I joined medical college in 1992, endometriosis was a very rare entity. But then suddenly the number is growing, and now you can see endometriosis. So incidence is so high that it is responsible for almost 2 to 10% of of general population patients, And can anybody tell me what is the incidence of endometriosis in infertility? Because we are discussing infertility and endometriosis today. And so can anybody tell me what is the incidence of endometriosis in infertility?
30 to 40%, sir. It's
almost
almost 30 to
40%.
40%.
30 to 40%.
30 to 40%,
Yes.
yeah.
I think most of the panelists, they agree that the incidence is 30 to 40%. But if you look into the new guidelines of endometriosis, it is said that the endometriosis is seen in 2 to 10% of general population and up to 50% in infertile women. 50%. So much high is the incidence, and that is the reason why we are discussing this topic today. So come September 2022, and then came the guidelines of endometriosis, and we were waiting for these guidelines since long, because actually there were guidelines which were initially there in 2014, but they were old guidelines and the things changed drastically, and therefore huzur aate aate bahut der kar di, but now we are having these guidelines which are actually what we are going to discuss today. So I'll start with a case of Neha, and these are the clinical vignettes, and I must say that all the characters are fictitious and any resemblance is just a pure coincidence. Neha is a young girl. She is just 28, and this is her story. She says that I am just not sure about my marriage. I'm already 28, and everyone says that this tall, beautiful Neha should find a suitable match. And I remember that during our college days, we used to discuss this, that endometriosis is usually associated with tall and beautiful girls. Maybe and with fair skin, the endometriosis is more common. That is what was our belief that time. But now the endometriosis is becoming so common. But coming back to the story of Neha, the Neha says that they are not aware of the severe pain I have during menses. And as far as relationship is concerned, I am so scared. I cannot think about relationship. And my gynec says that I have severe endometriosis. Now, this is a typical case of Neha. And if you just look into this endometriosis, you should actually read this book, Ask Me About My Uterus by Abby Norman, where she has narrated her story of endometriosis. And there she has said that there is something called as hysteria. And hysteria is something related to women's some psychological problem. But hystero means uterus. And therefore, it is said that this hysteria is something related to endometriosis, probably. So maybe it is the endometriosis which has got some relation with hysteria, and therefore we say, when we say women are hysterical, they have some problem, maybe endometriosis. Now we know that endometriosis is in everywhere. You may get it in the uterus, you may get it in the brain, you may get it in the lungs as a catamenial pneumothorax, and you may get it even in bladder, as Dr. Agrawal has rightly said, and he has also displayed the videos, also beautiful videos. Now, the first question which I would like to ask you is, and we are discussing the guidelines. So I would like to know from you that how you manage a case of endometriosis, and then we will discuss the guidelines and we will try to match our treatment plan with the guidelines. And because this is a panel discussion, so I want you to discuss everything, whatever you are doing at your center, right? Now, the first question is, can clinical symptoms predict the presence of endometriosis? And I want answer from any of the panelists that can symptoms predict the presence of endometriosis?
Yes, yes.
Definitely yes.
Yes.
And what is more important is you should have a high index of suspicion, because unless you have a high index of suspicion, you may not be able to diagnose some conditions like catamenial pneumothorax or dyschezia or easy fatigability, or even for that matter irritable bowel syndrome. So you should have high index of suspicion as far as the endometriosis is concerned. Now the next question is, now we are discussing a case of Neha, and we are starting with the basic thing. How do you diagnose endometriosis clinically? I am asking you a specific question because we are discussing a case of Neha. She is 28 years and she is unmarried. So our teaching is that you should not do PV examination for a young girl who is unmarried. So anybody from the panel, tell me, do you do PV examination in such situations, or you avoid PV examination?
We have to
We
take
can do
her
a per rectal examination.
Per rectal examination first.
If she's
If
ready
she
for
has
that,
had
we can do a
sexual
per rectal
intercourse, then we can also do a PV examination with her consent.
Okay. Now the consensus is, and this is what is our teaching, that you should do PR examination. But can anybody tell me? Imagine doing PR examination. in a 20-year young girl, Neha, she is already, maybe trying to find a suitable match, but she is scared because of her endometriosis. In this situation, do you think that PR examination is really a good experience, or is it PV which is better than PR? Because if you just look into the guidelines say that PV examination should be done in endometriosis, and if required, maybe you can do PR examination, which will be helpful in the diagnosis of endometriosis. But PV examination should be done irrespective of her sexual history or sexual life. So what I mean to say is,
we need to
yes,
take her. We
Consent.
need to take her consent. We need to first ask about her symptoms. If she has severe dysmenorrhea and we have a strong clinical suspicion, it is better to take her in person and ask if she is sexually active and take
exactly.
consent and do a PS and PV
No,
exam.
I will say a little different thing. So, in case she's having severe endometriosis, and if it is a deep infiltrating endometriosis, PR should be able to give us some diagnosis. And why do we want to disturb her by doing a PV or a PR? So you can just find, because the only thing which we do not want to miss is an endometriotic nodule. Otherwise, you can simply take her for an MRI. I mean, just take, because
Right.
we want to make the diagnosis of the ultimate point is not to do a PV or a PR, but just to validate her symptoms and establish a diagnosis of endometriosis.
So
Right.
I would start with a trans-abdominal scan.
And in our clinic, we do a lot of transrectal ultrasound also, which gives us lots and lots of information. And most of these girls who are unmarried, we are putting in the probe through the rectum and
transrectal.
information.
I would say that
As
instead of using a
in
word unmarried, we can use a word of sexually active or
Sexually
active or
inactive or sexually active, right?
So
in case she's
many
active, then yeah.
so many interesting things are coming up. See, and now the next thing is ultrasound. So we are already on ultrasound and MRI, as you have already talked about MRI also. Now, I just want to know whether transvaginal sonography is recommended in endometriosis or not. Again.
Definitely, yes.
Yeah,
It is the
it's
first
recommended.
line
Yes,
of
yes.
So
diagnosis
if you just
management.
look at the guidelines they very clearly say that transvaginal ultrasound is recommended to be used in adolescents, even in adolescents, in whom it is appropriate, as it is effective in diagnosis over an endometriosis. If a transvaginal scan is not appropriate, right? So see the wordings. In adolescent girls, if the transvaginal sonography is not appropriate, then as you have rightly said, MRI, transabdominal sonography, or even transrectal sonography should be considered. So see the wordings, and the wordings, they are so clear, and this is what actually you all are doing. So you have already mentioned about taking the consent of the patient, talking to her, taking her into confidence, and maybe if she is comfortable and if it is recommended and appropriate, you may do TVS examination also. Now, I just want to know, since it's a panel discussion, what are the situations where you do MRI? Because you have already talked about MRI. What are the situations where you do MRI? I just want to know, because I personally feel that ultrasound is becoming so good and technology is so good that very rare situations you may have to go for MRI. So anybody can just tell me the indications for
Obstructive
MRI in your
symptoms.
clinical practice.
Obstructive
Yes.
symptoms.
For
In
surgery,
cases
if
of
we want to
obstructive
know how
symptoms,
deep is the endometriosis, then I think we can do an MRI just before surgery
only
to find out
in
how
case
the
of
extent of
obstructive
depth of
symptoms.
endometriosis.
If we have a strong suspicion of endometriosis, but in sonography, we are not getting anything. In TVS, we are not getting anything, but we are still very suspicious that yes, this patient, based on her symptoms, may be having endometriosis. Then also we can go ahead with an MRI.
So let's say if she has dyschezia, she has bleeding, she has bladder symptoms, extra peritoneal,
Extra pelvic symptoms.
Yeah, extra pelvic symptoms.
Exactly. Now I think the answers are going in the right direction, because whatever you are telling is exactly what guidelines also say, that consider pelvic MRI to assess the extent of deep endometriosis involving bowel, bladder, and ureter. And even if you just look into the Foxy guidelines, they have said that MRI can be done to differentiate between the dermoid and endometrioma. So that is what Foxy says. But all the SRA guidelines, they have clearly said that DIE is something where you may actually go for MRI. And there is one more interesting thing which they have said, that please put a footnote that the MRI and ultrasound report may give you false negative results. That means even after doing MRI, you may miss the diagnosis of endometriosis. And then comes the advanced investigations. And can anybody throw light on anything beyond MRI?
No.
Anybody having personal experience of doing any such investigations, like you can see on the screen? There is something called as magnetic resonance elastography, CT scan, and PET CT.
No role. No role of such high-end investigations, sir.
So for some cases, you might have to give contrast with MRI. That is all which is there. But I personally have not recommended, even for extrapelvic endometriosis, any of these tests.
Because endometriosis is something which is like spreading like malignancy, and therefore, do you think anybody has ever thought of doing PET scan or PET CT in such situations?
For what? PET scan for what?
It can be promising for future. Maybe this may help in finding out a very deep endometriosis, like endometriosis in lungs or some other places.
Or maybe it may be helpful for a pre-surgical mapping if we are suspecting a very deep infiltrating endometriosis and taking her up for surgery. Maybe it may be used.
So this is a 2024 presentation where they have said that we postulate that improvements in the quality of life of patients will be accelerated by reframing endometriosis as a multisystem disorder and learning from treatment targeting symptoms shared between endometriosis, neuroinflammatory, and gastrointestinal disorders. So they have, now broadened the base of the endometriosis, and they are considering it as a multidisciplinary or something which is involving neuroinflammatory and gastrointestinal disorders also. And there they have said that endometriosis may be diagnosed with improved care if you do magnetic resonance image elastography, or if you do CT and PET scan. But I think this is something just a food for thought. Maybe in future this may come up, but as far as our panel discussion goes, nobody has ever done these advanced investigations, right? Now we come to the serum markers, and how many of you do CA125? सही से बताओ और ईमानदारी से बताओ, कितने लोग CA125 करते हो और कौन नहीं करता और कौन करता है, और कोई करता होगा तो कब करता है, क्यों करता है?
No role, sir. No role.
No role. Absolutely no role.
No role. Very low specificity, and it can be elevated in many benign conditions.
Yes. Even inflammation can have.
Right.
Yeah.
So I want exactly. So I want justification of no role. One thing you have said is non-specific. Yes. Second thing you have said is it is raised in many other conditions. Can anybody tell me any other justification for not doing CA125?
So basically, CA125 rises in a lot of inflammatory conditions.
Yeah. Right. Even in fibroids, genital tuberculosis. Yeah. So if you just look at the guidelines, they have given a very good justification. They have said that if you get negative results, you may miss the diagnosis, right? And if you get positive results, then in that situation, this positive result adds to the anxiety and over-treatment. And therefore, in both the situations, it is irrelevant. So we all are on the same platform that CA125 is not at all indicated in endometriosis. It should not be done. The justification is that negative results, you will miss the diagnosis, and positive results, you will lead to anxiety. Exactly. Now, so in case of Neha, where we are talking about the endometriosis, and she knows that she has endometriosis, and she knows that there is a problem. What about laparoscopy for the diagnosis of endometriosis?
Not recommended only for the diagnosis. Not recommended for diagnosis.
Not at all recommended. So in case of Neha, there is no role of laparoscopy, right?
Yes.
Because only for diagnosis, right? And
Yes.
if at all, you do laparoscopy, if at all, say somebody says that I would like to do endometriosis and so laparoscopy and see that there is endometriosis, and really there is some lesion or some nodule there. Is anybody of you taking histology to confirm the diagnosis of endometriosis? Because guidelines say that histopathology should be done and histology should be done to confirm the diagnosis. So how many of you are really doing histology? Because I am not doing it. That's why I'm asking.
No, sir. I
We are
do.
doing it.
So I'm also doing it.
Yeah, as a rule, whatever you take out from the body, you have to do a histopathology.
You
for
have
the
to do a histopathology, correct?
rule out other
So-
things also.
So I think the discussion is going in this direction that if you want to be medico-legally safe, if you want to confirm your diagnosis, you should, as the guidelines have already recommended, you should do histopathology to confirm the diagnosis of endometriosis, right?
Yeah.
Sir, fertility preservation
Negative
before
histology will
proceeding
not
to
rule
the-
out endometriosis.
Yeah, so it might not, but
Negative
then
histology will not rule out.
It might, that there is a possibility, but then I think it's okay. You should do.
Histopathology may not be correct or conclusive at times. It's better to give the recording to the patient, and I think at many
Visual
times
impression,
you can see
yeah.
visual impression, and it can second the diagnosis.
I am also of the same opinion that in endometriosis, visual impression is more important, and you may miss the diagnosis of endometriosis on histopathology, so it is better to avoid it. But the guidelines say that you should do it. Anyways, so we have now come to the end of story of Neha, because now we will go to the next case, which is a case of infertility. But I just want to ask you, now Neha is unmarried, right? And we have touched this topic of endometriosis in Neha, and she's 28, and we know that endometriosis may lead to diminished ovarian reserve also. So anybody of you would suggest fertility preservation in such situations?
Definitely.
Yes, she should. Everyone will do that.
We should counsel
So
her
that would
about
depend
fertility
upon other factors
preservation.
also. No, we have to have a surrogate marker, like we can do an AMH, get the scan, like if a transabdominal scan or TAVS is being done, we can see the AFC
Right.
also. So it has to be
Right.
correlated.
Exactly.
Sir, if you don't advise fertility preservation, it can become a medico-legal issue later. That my doctor didn't advise and took me for laparoscopy. Also, it is very important to advise fertility preservation, especially in a case of endometriosis.
I would say,
Let her
not
take the
advice, we would
decision.
say discuss about
we will counsel
fertility
her
preservation.
definitely.
Yeah,
And
counseling and
counsel
discussion.
her,
Counseling
this
is
very
important.
important.
Counseling of the patient should be
I
done.
think one very important thing in patients of endometriosis at the age of 28 is that you should discuss about their marriage also with them. So these are the
Actually.
females who
So-
should, they should plan their marriage early, because definitely these are the females who should plan their reproduction,
See, this
and
is
there a
old
reproductive
school
career
of.
which we talk to them.
It is not
and
in
this
our
is-
control.
Yeah.
This is old school
Yeah,
of
yeah,
thought.
correct.
Old school of
Now
thought.
we're
but
not supposed to
I
tell that get married, get pregnant.
She's a
I
tall,
also
beautiful,
belong.
talented woman.
We should
No,
at
no,
least
but
discuss. If she wants to, then
Yeah.
it is fine. She should at least
Yeah,
know
yeah.
it.
Please, she should know that her fertility can be a challenge. A lot of females, when you discuss with them all these options, they do take these things as very, very important. And in case she doesn't wish to, then obviously fertility preservation should be discussed with her.
And we should write in our prescription that
Counseling
fertility
of-
preservation has been
Yes,
discussed
true,
with her.
true. Correct.
Yes, true.
Yes.
I
Counseling
think this
should be
is.
done. Counseling
I-
should be done. Patient should be informed at what is the course of the disease, how it progresses, what it can lead to in the future, and let the patient be of.
And it should be
That will be a
documented.
good.
Yes.
What we do is counsel the patient. Then everything should be documented. Yes, that we have counseled the patient. That is also important. That we have to
Very true.
document that you have counseled the patient, have informed her about everything, the progress of the disease and all.
So for the first time, these guidelines have touched this topic. I belong to the old school of thoughts, and therefore I always, whenever I meet any young girl, if she's 28, then first thing I do is उसको फुकट का सलाह भी बोलते हैं. फुकट की सलाह देता हूँ कि जल्दी शादी करो और जल्दी बच्चे पैदा करो और 30 के पहले एक बच्चा होने दो. But this is what is the old school of thought. The young generation, young girls sitting over here on the panel, they would always suggest to go for ooset freezing, which is also an option. I think, and even in Nagpur, I see so many young girls coming. Every month we have 2-3 patients for ooset freezing now, and this is becoming a trend, and you have to follow the trend. That's all. So yes, you can just definitely think of fertility preservation in such girls, because she is 28 and she is not yet married, and there is a possibility that the ovarian reserve may go down or may have already gone down. We just don't know. Right. So we go to the next clinical vignette, and that is a case of Satish and Soumya. So Satish says that, hi, I'm Satish and I'm banker working with SBI. Me and my wife Soumya are very happy because my printer is almost all the time it's out of order, and therefore since SBI is known for out of order printers, I'm very happy. I'm enjoying my life. We are married since 2 years, but nowadays Soumya is worried as everyone is asking about good news. But we do not have any problem. But Soumya experiences Soumya pain during period. That's all. So only thing is she is having mild pain during menses. That's all. I mean, I don't know why, but it is just not happening. I'm planning to consult a doctor this weekend. So Soumya and Satish, they go to a doctor, a fertility expert, and then all the investigations are done. And AMH is normal. In her situation, everything
Your
is normal.
screen is not visible.
Oh. काहीतरी
Yes, sir, we can see now. Sir, you are muted. Sir, you are muted.
Hi, Chaitanya sir, you are on mute.
Chaitanya sir, you are not audible. I think you have. Yes, sir.
We can see now, sir.
And I am audible as well.
Yes,
Yeah,
sir.
you're audible.
Yes.
Okay. So everything in her case is normal. So how do you proceed? Can you consider the diagnosis of endometriosis even if clinical examination is normal? This is my question.
They are married for 2 years, and
Married for
she's
2 years.
having a dysmenorrhea. So we can, for the dysmenorrhea, we can give her some form of NSAIDs, mefenamic acid, and we should advise them to try and we start trying naturally if they have not tried till now.
Right.
And if they want to delay the pregnancy, then maybe embryo freezing or something like that can be advised to the couple, because endometriosis is associated with diminution of ovarian reserve.
But she has not been diagnosed as endometriosis right
So this
now.
is this is
Yeah,
exactly what is my question is, can you consider diagnosis of endometriosis in such situations where there is absolutely everything is normal, she is having slight mild pain during menses, that's all, AMH is normal, tubes are patent, her age is just maybe 26.
Minimal endometriosis can be associated with only dysmenorrhea.
Yes.
Exactly.
It
So
may not have any imaging finding.
Minimal or mild endometriosis, and she should regularly proceed with the infertility treatment which we want to do.
So initially we
for
discussed
2
about,
years.
yeah, so she's married for 2 years. So initially we discussed about high index of suspicion, and we have to keep this high index of suspicion in case of Soumya as well. Now in so as far as the endometriosis is concerned, now a case of Soumya, will you do laparoscopy? Because now in the first case there was no role of laparoscopy.
What information will
No,
laparoscopy give us, and how will
No
it change the management? Nothing.
We'll start with medical management and
I think
counsel them to
She is not symptomatic, actually, much symptomatic. So
Not much
she'll be,
symptomatic.
yes. So
where is
laparoscopy.
the laparoscopy placed? Where is the role of laparoscopy, and when is the role of laparoscopy in
severe
case of
pain,
Satish and
not
Soumya?
treated, not managed by medical management? Maybe there.
Pain and infertility.
And
Suspicion of
maybe we are trying to
malignancy.
conceive, having planned relation for 2 or 3 cycles, or we are suspecting unexplained in this case. It is just the clinician who is suspecting. We can advise them to go for IUI even, and if it is not working out, then maybe go for laparoscopy, because I assume on sonography everything is normal. Her tubes are patent, husband's semen analysis is
Yes.
normal, and she's less than 30. So give her trial of having planned relations first, and maybe then
Yes.
treating it as an unexplained rather than imposing a diagnosis of endometriosis directly straight away and guiding laparoscopy. Better would be go stepwise, and if it fails, then better go for laparoscopy. And
Right. Can you see my screen now? Or it is
No, sir. The
disturbed?
screen is there, but then it's gone. I think somebody called you, so the screen went off.
Actually, what is happening? Just wait.
but we can hear you, sir.
Yes, there now.
We can see.
So
We can see.
yeah. So I think what I feel is laparoscopy can be done in such situations where there is a mild endometriosis suspected when you have tried maybe 2 to 3 cycles of time intercourse.
Yes.
Will you do it before IUI or will you do it after trying 1 or 2 cycles of IUI?
After IUI, it's very, very
How-
clear that it has to be done after IUI.
After failed IUI cycles, ideally.
So how many cycles of IUI you will try first?
3 cycles.
3 cycles we
That
can
is
try.
your own clinical
So
judgment.
she's
You
less
want to
than 30, so 3 cycles can be tried considering she is asymptomatic mostly.
Okay. So now we have gone for this IUI cycles, and 3 cycles we have already exhausted. Now we know that not more than 3 cycles usually are advised as far as the IUI is concerned these days. So I personally feel that you should keep laparoscopy somewhere after doing maybe 1 cycle of IUI or 2 cycles of IUI, because you should give this high index of suspicion, and you should also think of maybe some adhesions or maybe some endometriotic nodules or lesions which are missed on ultrasound, which may be detected, and maybe some problem with the tubes which is not picked up on HSG. So these are the subtle changes which may happen. So what I think is laparoscopy has a role to play in case of Satish and Soumya after doing maybe 1 or 2 cycles, 2-3 cycles of time intercourse and 1 or 2 cycles of IUI. So the place of laparoscopy is not after 3 cycles of IUI, because then you have exhausted 3 cycles, and usually we don't go beyond 3 cycles these days. So I just want to ask you about the endometriosis fertility index. But I think everybody has talked about this because I was listening to Dramni Devi, and she also stressed about on endometriosis fertility index. So how many of you are seriously and really doing AFI in your day-to-day clinical practice? Or maybe after today's webinar, we all will start doing AFI?
So we as such are not calculating, but yes, endometriosis fertility index is something which Adamson started in 1989, and it is actually a very, very good tool. Actually, it it has a lot of criteria. The least functional score is something which is very, very important in this, and along with that, it takes age and duration of infertility, previous laparoscopy, and all that into consideration. So the score which comes can be very nicely correlated with her chances of getting pregnant. So I think endometriosis EFI is something which is very, very good. And in such cases, because instead of a laparoscopy, 3D scan and MRI and maybe a TVS also can be used now. Nowadays, the current trend is that even TVS, a good transvaginal scan, can be applied to an endometriotic fertility index, and EFI can be calculated just on the basis of TVS without doing a laparoscopy. So I think there is no role of laparoscopy in this, just because she has patent tubes and just because she's not getting pregnant, and you want to, maybe, if in case you feel that her EFI is higher and her EFI is higher, I think she should be given chances of IUI. Otherwise, she should be straight away for ART.
Right. So AFI is going to, it has got a a great value because it is validated, reproducible, and cost effective. But then this is a food for thought that you can actually avoid doing laparoscopy, and you still can think of taking into consideration the factors which may help you in deciding the course of action, whether to go for IVF or maybe try 1 or 2 cycles of IUI as well. So that is about EFI. But I think the take-home message is very loud and clear that if you are doing laparoscopy, then you should always do EFI. These days, EFI has got a great significance as far as the treatment direction of the treatment is concerned, or the treatment plan is concerned, and therefore EFI is becoming very important. So all the guidelines, they are mentioning EFI along with laparoscopy, and they say that you must do EFI because you know whether to go for IUI or to go for IVF depending on the scoring systems, which includes history as well. Now, I just want to ask you, yes,
Sir,
yes.
sorry, I would like to add, we have
Yeah.
to rule out male factor infertility before proceeding for laparoscopy.
Absolutely.
Take her for
Now,
laparoscopy, see a
yes.
sample with oats. I think that laparoscopy doesn't, have a chance. So we have to rule out other causes of infertility.
Now, right. So now that we are discussing this case of mild endometriosis, and maybe we have come to the conclusion that this is an endometriosis which is creating a problem, would you start this was some study which says that even metrogyl can be used in endometriosis because it is an inflammatory disorder. And then there is a 2024 study which says that probiotics have a role to play in endometriosis. And then there is a gut brain axis, then there is a irritable bowel syndrome, and then there are so many types of food, gluten free diet and other diets which are available, which may be tried in in endometriosis. So anybody from the panel going beyond the conventional treatment and thinking about the probiotics and gut brain axis as a cause of endometriosis, and trying probiotics and metrogyl and other things.
Experience, sir.
No experience.
Diet modification. I'm doing advising a Mediterranean type of diet to the patient, and in
Yes, I
lifestyle
think.
modification,
Yes.
daily exercises and yoga, and this all really helps the patient. So diet and lifestyle modification definitely I'm doing for my patients with endometriosis.
I think this is a
So that also helps the patient. The
this
diet
is a
also plays a very important role.
point well taken. Lifestyle modification and diet modification. At least you can start with this. And as you have rightly said, Mediterranean diet is something which may help you in treat, not exactly treating, but helping in the treatment of endometriosis. But you can also think of starting probiotics as well in this situation. So maybe
Yes,
soon
probiotics
the
also comes in a big way.
pharma companies will soon come with this products for endometriosis, and then you may get an opportunity to give a talk on probiotics and endometriosis in the near future in conferences. So anyways, there is one interesting fact I would like to share with you, that there is something called as endometriosis clinical and genetic research in India, ECGRI trial. And this is an ICMR trial which is actually just now they have completed, and they're trying to find out the trends of endometriosis in India. Dr. Rahul Gajbe is the principal investigator, and Smita Mahalle is the supervisor. This is the ICMR trial, and I was very lucky that I got an opportunity to become part of this trial. There were 6 centers all over India, and we could give more than 200 cases in just 4 years time. The number of cases we gave at Nagpur, staying at Nagpur, was second number after Manipal University. So maybe this suggests that the number of endometriosis cases is increasing in central India as well, because till now we had this notion that South India endometriosis cases are more common, and in North India and in Central India the number is less. But I was really surprised. We got so many cases, and the 200 number we could achieve in just 4 years, where there was a trial of 5 years. So I think that one thing is very clear, that number is increasing, and therefore that is the reason why we are discussing endometriosis today on this panel. So we come to the last case. Maybe we have 15 more minutes, or we should stop here. I don't know, because we lost so much of time in this goof up. So shall we continue with the last case, or shall we stop here? Archana madam?
We can take.
Sir, I think the panelists are ready to take the more questions.
Yes,
so
sir.
I
Yes,
guess
sir. We can take
Great.
the last.
So I'll take a last case now, and this is a very important case because this case is related to severe endometriosis. Kahani Karuna ki. Karuna is not so lucky. Soumya was lucky because she had mild endometriosis and she could conceive with second cycle of IUI. But Karuna is not so lucky. Karuna is married since 10 years. Her age is 34 years. Okay. Her first laparoscopy was done 8 years back for chocolate cyst, and that time there were adhesions. Now she, after laparoscopy, she received Leupride and IUI was done 6 times at that time, and now there is a recurrence of cyst, and now she has got a cyst of 5 centimeter. Her AMH has gone down to 1.2, and she is having classical severe endometriosis. I think here one point which is very important for all of us is first surgery should be the last surgery, because you know the recurrence is so common that you should always think of getting the surgery done by an expert who is doing laparoscopies for severe endometriosis regularly, because laparoscopy plays a very important role, and if you don't do it properly then recurrence is very common. Now in this case of Karuna, what is your plan of action?
IVF.
So there is no role of repeat surgery
No
in
role of repeat surgery.
endometriosis.
So I would definitely like to go ahead with IVF.
Absolutely.
AMH is also coming down 1.2. So
Right. So everything is
surgery and
now
cystectomy will further decrease it.
yeah, everybody is clear, ideas are very clear that nobody would like to go for laparoscopy here because there is a recurrence, but straight away start treatment for IVF. Right, and this is what is recommended. So we will do we'll plan IVF and you do TVS, and you just see now that IVF is in offing and you have this in mind that you have to go for IVF, what are the things which you will look for in TVS in the case of Karuna?
We will see whether the
Is
ovaries
possible
are accessible or not.
Accessible, yes.
Accessibility of the ovary and whether we can
follicles, we will
treat
see
the
how big the
follicles.
endometrioma
Yes.
is.
Size of the endometrium.
I think that is the first thing that comes to your mind, that accessibility of follicles is very important for us because we are planning IVF, so you'll have to go for ovum pickup. And we all know the guidelines which are very clear that you should not puncture endometrioma, right? That is very clear. So you see for the accessibility of follicles, you see the antifollicle count, and then you also see for the endometrium, because you know that endometrium is also affected in endometriosis, and maybe she may have associated adenomyoma, and endometriomyometrial junction is also important for us. So this is how you try to assess the case. And now one very important question. This is a very sensitive topic and you all have already given the answer. Is there any role of surgery in a case of Karuna?
Repeat surgery.
One thing is clear, we will go for
laparoscopy.
IVF. One thing is clear, we will go for IVF. So our first choice will be to stimulate her, get enough number of embryos first. Only thing is, we will plan surgery if her ovaries are completely inaccessible for follicular retrieval. But if we can retrieve the follicle, I think first we will go for freezing her embryos, and only if like her lining is not forming properly or she has severe pain or the size of endometrioma is a very large one, only then we will plan surgery, maybe after freezing her embryos and before her transfer. So that
Absolutely. I think the complete case you have discussed in this your answer, that you will never go for surgery before going for ovum pickup, and the only indication for surgery is of course pain. But even in that situation, I think we should try to get as many oocytes as possible and then only go for embryo freezing, and then if required, we may go for surgery. And there is a very important recommendation which is given by the ESHRE guidelines, and this recommendation is something which we all should keep in mind. if at all, in any situation, we are going for in laparoscopy or endoscopy in endometriosis. What is that recommendation? The recommendation says that clinicians should counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and possible loss of the ovary. And this counseling should be documented because there is a very high possibility that patient will undergo surgery, will do her repeat AMH, and will come to you and may start, accusing you that it is because of your surgery that my ovarian reserve has gone down. And therefore, even if you are a very good surgeon and even if you're doing it very carefully, there is a very high chance that you may actually reduce the ovarian reserve because of your surgery. Now, I just want to ask you, anybody for any alternative therapy? Now, we are very clear. We all are IVF consultants. We all are clinicians, majorly into IVF. Therefore, laparoscopy is not our first love. We always, try to avoid laparoscopy in endometriosis because we are all are clinicians doing IVF. So, anybody, can anybody tell me about any alternative therapy which is mentioned in the books, and anybody has tried any alternative therapy?
Sir, one thing I wanted to add was before doing a frozen embryo transfer, also we should do a down-regulated frozen embryo transfer for this female, because endometriosis might be associated with adenomyosis also. So before frozen embryo transfer, we can give 1 or 2 doses of Lupride to her.
Exactly. I think this is a situation where there is a role of long agonist down regulation, because it will help in endometrial receptivity as well.
Yes.
In such cases, we are usually doing the ovum pickup. See, patient has already undergone a surgery, so definitely we would not want to repeat the surgery, and that too with a decreased AMH. So in such cases, what we usually do is we do the ovum pickup, then we give monthly 3 doses of Dupo preparation of GnRH analog, and then we go ahead with the transfer. So that improves the endometrial receptivity also, and patient is relieved of pain also, and the results are also better. The implantation rates and pregnancy rate is definitely better.
Absolutely. Now, I would like to share with you what we used to do 20 years back when there was no frozen embryo transfer or no frozen cycles, because we knew that if you are freezing the embryos, you will not get the results. So only fresh transfer. So what we used to do, exactly what Salam has told or discussed 20 years back, or maybe in 2004, he has said that if you give Lupred for 3 months and then do IVF, then the success rate improves 4 times. 4 times. So this is something which was really fascinating, and therefore we always used to do this. We used to give Lupred for 3 months and used to do the pickup, and ultimately, what we used to end up getting very few sites because the HPO axis is so suppressed with 3 to 4 months of Lupred treatment that we used to get very few follicles and then very few sets, and ultimately the end result was not good. It was negative. So then came the new guidelines, and there is a total U-turn, and now it is said that long-term Lupred treatment of 3 to 4 months is not indicated in endometriosis because it will ultimately lead to the suppression of the HPO axis. But as you have rightly said, 1 cycle of long agonist protocol followed by transfer, that is down-regulated transfer, is something which we all should think of, because it will improve the success rate in the embryo transfer, receptivity of the endometrium. So I was coming back to the point which I was discussing. Any alternative therapy, or have you anybody has tried any alternative therapy? This is something interesting which I got in fertility sterility, one of the videos, which says that you can actually do sclerotherapy. And even the new guidelines of 2022, they have mentioned about ethanol sclerotherapy as an alternative treatment to reduce the size of endometrium or to take care of endometrioma before going for the ovum pickup. I really don't know. Of course, we don't have it, but then yes.
Yeah. Sorry, Dr. Neeta Singh from AIMS, she has done a lot of work on sclerotherapy, and she had presented this in ASRM also, and with very good results. In fact, now it is being recommended and it is coming in guidelines also that you can use sclerotherapy as an alternative treatment to enucleation. and it impacts. There is less impact on the ovarian reserve, and it could be especially done in females with with poor ovarian reserve. And
yes.
yeah. So
Yeah.
ma'am
I think
presented
I have.
in the mean, and it was,
Actually,
and she had
I
some
do
very
have
good results. Yeah. Yeah.
No, I too have done this sclerotherapy. I aspirate if the not the very big follicles, not the very big cyst, but if the cyst is like in the range of 4 to 6 centimeter, then just aspirate and then give the escarole. So I have tried, and in some patients, so it has been very good with no recurrence. And last 1, 2 patients I have got recurrence also. But actually, it
Okay.
works well.
Yeah.
Yes, I think this is something food for thought. We all should try this, and because it is mentioned in the guidelines also.
Yeah.
And anybody for microwave ablation of adenomyosis before transfer? Anybody having any experience of, because microwave ablation is also now coming in a big way.
Yes.
Yes, because now Dr. Suyash Naval, he visits our center for advanced endometriosis treatment, and he is doing this microwave ablation. Even he is doing it at Apollo Hyderabad also. So I think this is something which is now coming, because adenomyosis is something which is really frustrating, and we all know that this adenomyosis is going to reduce the endometrial receptivity, and the surgery for adenomyosis is mostly not so rewarding. So maybe microwave ablation is something which is new kid on the block, but which will come up in a big way, and maybe it will help us in getting good results in adenomyosis as well.
So what
So
is
this is
your
about,
experience on this? You said, someone is coming at your clinic,
yeah,
Dr.
Dr. Suyash Naval is coming, and now we have decided to start this therapy at our center because he has got a microwave ablation machine with him, and he's doing it regularly at Apollo and at Jalgaon also. So maybe we are very soon we'll start doing this in our patients of adenomyosis as well, because he is already doing it at so many places. So I think this is new thing, but we all should start doing it sooner or later, because it is going to help us in improving the receptivity of the endometrium. So this is all about a case of Karuna, because now that we have come to the conclusion that in this situation we will definitely go for pickup first, followed by maybe if required laparoscopy, otherwise no role of laparoscopy, followed by maybe a cycle of one cycle of agonist, followed by transfer. So the story is complete. And as far as pickup is concerned, what do the guidelines say as far as the pickup in endometriosis is concerned with
Avoid
endometrioma?
puncturing the endometrioma. Avoid puncturing.
And if at all you puncture the endometrioma,
Antibiotic.
yes. So that is the only indication where you should you can give antibiotics to,
And if
right. And as
accidentally we puncture the endometrioma, it is better to change the tube and wash your
Cannabis.
needle before piercing to the another follicle.
Right, right. So I think I have again I'm getting a call from somebody. Okay, I just try to. Just give me 2 minutes. We'll sum up with the last slide, which is very interesting. That's why I want to just show it to you, if at all it is visible. Yeah. So that is all about endometriosis, and yes. So this is Kahani Karuna ki. This is the photo picture of Karuna taken during C-section, and you can still see some
The
endometriotic
screen
nodules,
is not visible.
but screen is not visible. Anyways, so this is the picture of Karuna taken during C-section, and you can still see some endometriotic nodules, and you can see the adhesions. But ultimately, she conceived and she delivered a baby girl. So as far as endometriosis is concerned, these are the new guidelines, and you can, if the it's are still there, you can take a picture of this changes in the guidelines, which are more important for us because we all know the old guidelines, and they have said that there is no role of laparoscopy for diagnosis. They have said that you should not give Lupret for 3 months before doing stimulation. They have said that there is no role of danazol, bye-bye danazol. This is what is clearly mentioned. And then this is very interesting. In 1776, Louis Brotherson has said that these women are given life sentence and they are trapped by endometriosis. This is what Louis Brotherson has said 300 years back regarding endometriosis, and which is so true even today. So endometriosis is becoming a problem, more and more serious problem for all of us. And one woman with endometriosis, she said, this is her expression, that when you are healthy, you have many dreams, but when you are ill, you have just one, and that dream is to come out of the illness. And that is exactly what all the endometriosis patients they are thinking. So thank you all for patient listening and such a wonderful panel. And before I end, I would like to wish best of luck to Dr. Archana Baser for her new role in Foxy for her elections. We all are with you. Okay. And
Thank you for the excellent panel, sir. We enjoyed and learned a
For
lot.
such a
Thank you, sir.
thank you so for such a
I
well
am
conducted
really
panel
sorry for the
discussion.
goof up,
In spite
but
of
then
all the hitches, we
In
really enjoyed
spite
it.
of all the glitches,
yeah,
it was very good. And
everybody
all
enjoyed.
the
Thank you,
Thank
best
sir,
you
to
for a
so
very
Archana
much.
nice
ma'am.
panel. Enjoyed it a lot.
Thank
Yes.
you.
Yes,
Thank you, Chaitanya sir, for a
thank you so
wonderful
much.
session. And thank you, all the panelists, for
Thank
enthusiastically
you.
participating in the panel. I think Dr. Rudri, you are there?
Yeah, we are here, Animesh.
Yeah.
Thank you everyone
Yeah,
for
ma'am is also
participating.
there. Yes, yes,
Thank
yes.
you
Over
everyone
to
for
you, ma'am.
participating. Chaitanya, we know is a good moderator, and he just keep you spellbound, and everybody really enjoyed. So thank you all. Thank you, Kanchan. Thank you, Sheetal. Thank you, Yukti. Thank you, Shivani.
All the best, ma'am.
Everybody, thank you so much.
We enjoyed, we
Thank you, ma'am.
learned today.
See you
We
in
learned a lot.
Chandigarh.
See you
Thank
in
you.
Chandigarh. Yes, I'm coming in Chandigarh on 15th. I'm there. So
Yeah.
we'll see you in Chandigarh.
All the best, Archana ma'am, for your next venture, and looking forward to see you at Raipur.
Surely, Tabassum, I'm definitely coming. Yeah. So still working, all of you, in spite of your working time, you could give some time to CME. So heads off to all women and all who joined here, multitasking. So thank you and take care. And
All the
now,
best,
Thank you,
ma'am.
Archana madam.
All the
All the
best.
best.
All the
And
best,
thank you
madam.
so
All the
much,
best.
Archana ma'am
Thank you
and
so much.
Rajwala ma'am. Thank you. All the
Thank
best
you
to you.
so
All the
much.
best, ma'am.
thank
Archana ma'am, all the best.
Thank you, ma'am.
thank you, Sonia. It
Yes,
was
ma'am.
nice
Wonderful,
connecting with you
wonderful
all.
All the
panel,
best.
ma'am. Very
And
nice,
I
ma'am.
really enjoyed all the talks. I mean,
Yes, ma'am. But
everybody was endometriosis, I think, inside out. So thank
yes, ma'am.
you.
Congratulations.
Thank you.
Bye
And
bye.
Dr.
Thank you.
Bye, Chaitanya. Thank you so much. And
Thank you,
look
Archana madam.
forward to see you all you at Indore. Come, all of
Yes.
you to Indore. And Rudri, yeah, Arpita ma'am, thank you so much. We are meeting again after Gayaji.
Yeah, thank you. And I told you na, that I will pray for you.
Yes,
And
you did.
after winning, you have to come to Devgar.
Yes, you did.
Really,
You
very,
did.
very informative webinar.
Definitely.
Thank you.
Bilkul. We'll be definitely coming to Devgar. So I think Rudri, who is proposing vote of thanks, and
We will be proposing, ma'am. Thank you so much, ma'am. Dr. Rudri,
and thanks to UNS as well. And yeah, please.
Okay, so ma'am should period ही नहीं आया उसका
तो थॉराइड करवा लो तब दवा लिख देंगे पीरियड
ma'am, should I start? If we end with the scientific program.
yes, Dr. Rudri, you can give the
Yeah.
vote of thanks. Thank you.
Yeah. Okay. So
big thank you to everybody.
नहीं तो ये दवा कोई मुड़ी भूंजा थोड़ी है कि जब मन तब खा लो पागल
Present right here. So thank you so much on behalf of entire MPSR team and to make this event a very big success. Thank you so much for joining us. And thank you UNS team for giving the technical support from backend. And we look forward to conduct more and more CMA like this. Thank you so much.
Thank you for the kind invitation, Dr. Rudri.
Thank you. Bye.